Great. After a little bit of dramatic entry, good evening, everybody. My name is Dr. Priyanka Joshi, and I come from a medical team of BSV, and I welcome you all today to Perfection 40 Sphere by ISAR. This is Symposium 2. This is a certified course, so at the end of the session, you'll find an option of downloading the certificate. So please stay tuned. So today's session will be on ovarian stimulation protocols, tips and tricks. The session aims to highlight practical, evidence-based insight to optimize ovarian stimulation strategies from tailoring protocols to troubleshooting challenges. And we'll explore various key tips that enhances clinical outcomes in the reproductive care. So thank you once again for being here today with us. So now let's dive into the informative and engaging discussion with our conveners and guests. I would love to initiate by introducing our convener, Dr. Monica Singh. Thank you, ma'am. She is the president-elect of Bhopal Ops and Gynae Society. She is founder president of ISOPAP Society, ISOPAP chapter of Bhopal from 2024 to 2027. She is a national executive member ESA 24 to 27. She is the convener for the following webinar series: ESA Perfection Series, Foxy Symbiosis Series, the Synergy Academic Club. So, ma'am, over to you.
Thank you so much, Priyanka, for those nice words. And it's always a pleasure working with BSV. Your team works like pros, and right from this second episode, it feels that we've been doing these programs for months and months. So, congratulations to you and your team. And can I have the program, please? Today, we are gathered here uh, to celebrate yet another webinar by the Indian Society of Assisted Reproduction, the Scientific Symposium 2.0 on ovarian stimulation protocols, tips, and tricks. I think I have to advance the slide. Is there, yeah, perfect. So here we are with the 2.0 Scientific Symposium, and the topic is very interesting. We started 1.0 with adjuvants in infertility, and we had already discussed laboratory adjuvants in the IVF lab in one of the Synergy series. So in continuation with this academic program and quest, we are today with a very, very hotly debated topic, always yearning for more information from experts in this. So today we'll be learning the tips and tricks from stalwarts in this field. We welcome amongst us the who's who of ISAR, our respected President ISAR, Dr. Amit Patki sir, Honorary Secretary General ISAR, Dr. Asha Baxi madam. Our chief guest is Dr. Dhiraj Gada, past President ISAR. Sir, because of family commitments, cannot join right now, but we have his blessings. We have amongst us a special guest, Dr. Brajbala Tiwari madam, who is Secretary of MP ISAR chapter. We have Dr. Fessy Louis sir, Vice Chairman of ISAR. We have Dr. Rajat Ray sir, who is professor in HOD at High Tech Medical College, Rourkela. And we have Dr. Kundan Ingale, who is Managing Committee member of ISAR and past chairperson of Foxy Infertility Committee as our guests of honor. I welcome also all of you, all the audience who's taken time to join us on this weekday. I thoroughly thank my co-conveners, Dr. Garima Sharma and Dr. Manisha Bajpai, both managing committee members of ISAR. I thank my co-convener, Dr. Randhir Singh, again managing committee member of ISAR, and my lovely coordinators, Dr. Purva Bhatkur and Dr. Shweta Agarwal, both academicians and thorough, very skilled gynecologists from Bhopal. So we walk you through the program before introducing our chief guest. Can I have the program slide, please? So we have a virtual academic feast in front of you. We will start with the Bollywood star, Dr. Jatin Shah. I was talking, he said, Monica, am I first? Monica, sir, you're always first. So, Dr. Jatin Shah talking about controlled ovarian stimulation across all spectrum. We start with this, very, very dynamic session, followed by controlled ovarian stimulation in IUI, because sometimes stimulating in IVF is easier than knowing how to stimulate in IUI cycles. So I guess the audience would be very eager to listen to this as well. And then we have Dr. Madhuri Patil, who will be tackling the toughest ovarian stimulation scenarios from a host of panelists drawn from all over the country and from ISAR, definitely ISAR members. So, without further ado, I would like to pay my warm regards and respect to our chief guest, Dr. Gada sir. Can I have his CV, please? First, I would like to introduce Dr. Gada, and then I will speak about our ISAR dignitaries. Our chief guest for the evening is Dr. Dhiraj Gada, past president ISAR. And with due respect to Dr. Gada, I would like to acknowledge him as my mentor. When I stepped into the field of fertility treatment and IVF, Dr. Dhiraj Gada held my hand and did a lot of troubleshooting for me. We just wish for his good health and good health and good long life and everything. And sir is not there amongst us today. He is at the forefront in not only national level in IVF, but also all over Madhya Pradesh. He is revered as a father figure. He took his education from Mumbai, and then he went on to become the president of ISAR. He is also credited with delivering the first IVF baby in state of MP, introducing ultrasound, introducing ART in the city of Indore in MP, and chairing various organizations, as well as honored by the Lifetime Achievement Award, not only by ISAR, but also by IFS. We thoroughly acknowledge his blessings and you know, we are missing Sir very much. Now, I would like to invite and welcome our President ISAR, Dr. Amit Patki, sir. I'm sorry for the slightly change in the schedule of the slides. The studio must be confused. I would like to have the slide of Dr. Amit Patki, sir. We welcome amongst us Dr. Amit Patki, who is President ISAR. Sir is Medical Director, Fertility Associates, Mumbai, and Honorary Associate Professor at KJ Somaiya Medical College and Hospital, consultant at Khar Hinduja and Surya Hospitals, Khar, Mumbai. He is the country representative of Aspire, Governing Council member ICOG, President ISAR, General Secretary MSR, Chair West Zone RCOG, President MOGS, with 35 publications in national international journals, 50 book chapters, edited 3 books, and 2 international patents in infertility and stem cell research, and a renowned TEDx speaker. He is credited with doing great national conferences in very recently in Lucknow. We had National ISAR, we had Yuva ISAR in Chennai, both for great success. And we look forward to ISAR embryology very shortly in September in the city of Indore under his leadership and under Dr. Asha Bakshi, madam. So, Shweta, has sir joined? Okay, we will wait for sir. We have already messaged him. Asha Bakshi ma'am is with us. Can I have madam's slide? Dr. Asha Bakshi needs no introduction. Her name is synonymous with Isar. It is synonymous with Madhya Pradesh. So, like Dr. Dhiraj Gada sir, I think Dr. Asha Bakshi is someone who brought ART in its full form to to the state of Madhya Pradesh. She belongs to the city of Indore. She's done a lot of work in the UK, but came back to India to start a state-of-art IVF center in Indore, and now she has a motherhood a chain of hospitals in Indore. She is holding the post of Secretary General of ISAR. She is looked up to for all various any problems we face, any queries we have. She's also the Foxy member representative of Ultrasound Committee of AOFOG and founder chairperson of MPIAG and MP ISAR. To her credit go the first ICSI, TESA ICSI and Micro TESA ICSI babies of MP. She is recipient of Dr. Kumar Tamaskar Award of Foxy and the best paper in Foxy Journal. Madam has organized several widely acclaimed and successful conferences in the city of Madhya Pradesh. Welcome, madam, and we are waiting to hear a few words from you, ma'am.
Thank you, Monica, for the kind introduction. It is indeed an honor to be at this platform. It's our own platform, basically, through the ISAR, through MP ISAR, and through Madhya Pradesh. ISAR, under the leadership of Dr. Amit Patki, is really doing lots of activities, not only physical, but webinar. And all these webinars are high quality webinars and being attended by great number of attendees. So that is the importance. And today also, if you look at the program, and it is amazing. Where can you find these three doing one platform? Dr. Sujata Ka, Dr. Jatin, and Dr. Madhuri. Monica, you are really, you must be having good relationship with everybody so that you could get all these stars at one place. So everyone is, I'm sure, eager to listen to these people, and they are really not, they will not just teach theory. They are so learned and so updated that you'll get lots of new points from them. And all our day-to-day problems can be solved, and we'll learn lots of new things. So I would like to congratulate you, and I wish you all the best for this webinar. So thank you very much, and keep doing the good work.
Thank you. Thank you so much, Asha ma'am. And you are virtually a chief guest today. You are representing ISAR, and you are representing Dr. Gada sir also from MP. So, Madam, with your permission, I would now like to introduce our special guests for the evening. Our special guest is none other than Secretary of MP ISAR, Dr. Braj Bala Tiwari. And we have amongst us Dr. Fessy Louis, who's also a special guest. Dr. Brijpala Tiwari has recently taken over as the Secretary of MP ISAR. She has also won a closely contested elections and is the chairperson of the Environment Committee of Foxy. So she is holding double posts. She is, in one hand, she has got ISAR, and the other hand, she is managing um, uh, Foxy. And along with that, she is managing a very busy practice, traveling all the time, but yet, like all the time she's smiling and all the time she's lending a helping hand. She has held a lot of important posts in IOXA, which is like what Indore Obsgyne Society Association is called. And she's also, we can see, she's very active in IMA, in ISOPAP. She's the secretary of ISOPAP chapter of Indore. AMPOX, she has held. She's done wonderful conferences along with Bapat Madam and Asha Baxi Ma'am and Basir Ma'am, AICOG, ISAR. She is the PCP entity representative to district
Thank
government.
you, Dr. Monica. We are eager to listen the academics. Thank you so much, and good evening, all the stalwarts. And thanks, Dr. Monica and Dr. Randit Singh sir, for giving me this privilege to be a guest over here today. And it's very prestigious series you are doing since years. That is Perfection series, and I am thankful to our President ISAR, Dr. Amit Patki sir, and Secretary Dr. Bakshi Madam for this platform, because many of us are taking so many practical tips through these webinars. And today's webinar, I think the stalwarts of is Dr. none other than Dr. Jatin Sasar, Dr. Sujata Kar, and Dr. Madhuri Patil herself is going to take talks on this ovarian stimulation. That is really very, very important. And I must appreciate your co-convener, Dr. Garima Sharma, Dr. Manisha, Dr. Purva, and Shweta Agrawal. You all are doing superb job. So many webinars and so many things, Monica, you are doing. And my sincere heartful wishes for your future endures, and wish to meet you on Sunday at Bhopal, your city of Lake. So I think we should go ahead with academics. Thank you so much.
Thank you, Braj ma'am, for giving us that special guest message as a special person. And our other special guest is equally special to us, Dr. Fessy Louis sir. Dr. Fessy Louis sir is another person you can always, he always has got a, very smart tip for you for use of new molecules. He taught me the utility of growth hormone during, a journey in a, taxi. So, Fessy sir, we are always indebted to you. You are the star of Kerala, the field of IVF in Kerala. Sir is heading the Amrita Institute of Medical Sciences. It is so well known and so widely acclaimed. At the same time, sir is again having the double responsibility of being triple responsibility of having, being active in Foxy. He was the Vice President South, ISAR, Executive Member, National Executive Member, and ICOG Governing Council Member. I think along with Secretary IAG Kerala chapter. So there is absolutely nothing which you is left out in your the itinerary, sir, and your this thing CV. And sir has already taken charge as president of KFOG, no, sir? You've
No,
already taken
next year.
charge.
Next year.
Next year. So he's president-elect of KFOG, again, a very, very big organization, very active academically, thorough gentleman, always giving us tips on how to improve our program, how to improve our presentation. And sir, we would like to have a few words from you.
Good evening to all of you. First of all, let me congratulate ISAR, especially Monica and Endir for having this excellent program of ISAR Perfection Series. And we all thank for our President Amit Patkisar and Secretary Asha Baxi Madam for continuing support. And I think today's not because of this episode of Perfection Series, but because of the content, the specific topic that is most important. Because all practicing infertility specialists, all at some point of time, they will have some confusion about the ovarian stimulation. That is the mainstay of their treatment. So we will be having today excellent talks and panel discussions by the expert in this field. And I think that, let me congratulate Monica and Dendir, and also co-conveners Gerima and Manisha and Dr. Purva and Sweda for selecting this topic and arranging in this perfect manner. I hope this will be there. Even if somebody miss, we can see it in the our ISAR website. Link will be there. So I think like this CMS, focus CMS will be really useful for the practicing gynecologists, especially the infertility specialists. So without wasting time, let me once again thank all of you for inviting me and wishing all the best for today's webinar. Thank you.
Thank you so much, Bessie, sir. And we would really be delighted if you could continue to be there in the program, because we'll be definitely taking your expert comments. And now we would go to invite our guest of honor for the evening. Dr. Rajat Kumar Ray has been with us right from the beginning, even before we began the program. And sir is again a very big figure in the field of Foxy ICOG ISAR. He is the professor and HOD of High Tech Medical College, Rourkela, National Dean of Indian College of Medical Ultrasound, Honorary Professor at IMA Headquarters, New Delhi, State President of IMA Odisha Chapter 2022, National Vice President of Foxy East Zone in 2018, Executive Member of ISAR, Society of Fetal Medicine, as well as the Indian Federation of Ultrasound in Medicine and Biology. He has been the governing council member of ICOG from 15 to 17, and Sir is director of Ray Hospital and Test Tube Baby Center in Rourkela. Welcome, sir. And we are so honored to have your gracious presence amongst us. And sir, we would like to have a few words from you, please.
Thank you, Dr. Monica, for giving me this opportunity. Also, thanks to congratulations to Dr. Andhir also. So, congratulations to both of you for arranging this type of webinars. And congratulations to National ISAR also under leadership of Dr. Amit Patni and Asha Baxi for arranging this type of webinars. And this is a very utilized topic. Today you have chosen a very good topic with stalwarts from ISAR. Thank you once again for conducting this type of webinars. Thank you.
Thank you. Thank you, Dr. Rajat Ray, sir, for being here. And now I would like to invite a guest of honor for his address, Dr. Kundan Ingale. Dr. Kundan Ingale, a very active figure, again, both in Foxy as well as ISAR, and a very dear friend. Kundan and Kalyani have been with us right from our beginning of journey in IVF. He is, again, a very lively person, very lively in academics, always reading new things, always coming out with new usage of drugs and protocols of his own. So soon, I think, Dr. Kundan, you will have the Kundan protocols, which you will be reading after. So he has held very important posts in Foxy ISAR. He has done a wonderful job as chairperson of Infertility Committee of Foxy, because I was working in his committee. I know how much hard work he put. He and Dr. Kalyani are doing lots of good work in the city of Pune through the Nirmati Clinic Endoscopy Center, as well as their ART bank, the Moses Cradle ART bank. Thank you, Kundan, for joining, and kindly address us with your precious address.
Thank you, Monica. First of all, heartiest congratulations for specifically, organizing this topics, speakers. The topics are perfect and the speakers are perfect for it. I think that's the heads up to you for organizing this. And ISAR, Dr. Amit Patki, President, and Dr. Asha Baxi, Secretary. I think we are having fantastic year going on in terms of academics as well as a very fruitful conferences. Uh, Ovarian stimulation, I think, friends, we all practice day in and out, and it's a fun to practice ovarian stimulation. I always say, if you take out a technical part of ART, this is a clinical part, ovarian stimulation, and we love doing it in every patient because every patient teaches us something new, and we take that challenge and we always modify our protocols so that we get the best out of our use protocol. So there was an era when ovarian stimulation was only one protocol, and everybody we used to practice just 10 years back, probably the same day 20 long protocol for every patient. And now it's completely different. The patient's unique characteristics, patient phenotype, everything matters now, and we change our protocol. So lot of individualization, lot of change in protocols according to the even clinical scenarios like endometriosis, PCOS. So I think it's a really fun practice to deal with the ovarian stimulation in each day's practice. I think, and now it's like that we can start ovarian stimulation in not only in follicular conventional phase, but at any time we say mid cycle or luteal phase. So as the situation demands, we can offer our patients at the earliest this kind of treatment. I think that everybody will agree that it's really a amazing part. And today we have Dr. Jatin Shah, who is again has a huge experience going to speak about different scenarios. Dr. Sujata Kar, another academician and our future president, I think she will again speak about protocols in IUI. And we have fantastic panel and moderators. I think we are going to enjoy this session. Over to you, Monica. Again, thank you for having me as a guest of honor. I will love to be a part of this. So thank you very much.
Thank you. Thank you so much, Kundan. And Kundan has given us the vitally important message. When you enjoy your work, it no longer remains work. It is fun.
Absolutely.
That is after this webinar, I think everybody is going to consider IVF as fun. But at the same time, we hold a very important responsibility of giving results. So over to my co-convener, I would like to just acknowledge, because of paucity of time, I acknowledge the great work and a lot of labor, hard work, consistency shown by my co-convener, Dr. Randhir, my co-conveners, Dr. Garima Sharma and Dr. Manisha Bajpai, always putting their inputs even when they are traveling. And then my coordinators from Bhopal, Dr. Shweta and Dr. Purva. So without wasting time, now I think I hand over the session to Dr. Purva Bhatkur, who is Assistant Professor in Gandhi Medical College, Bhopal, and to take the first session forward. Thank you very much.
Thank you so much, ma'am. So moving to our first academic session, that is on controlled ovarian stimulation across all spectrum. I invite Chairperson Dr. Seema Pandey, Madam. Madam is presently the Honorary Librarian of ISAR. She is Director of Seema Hospital Private Limited, EVA Fertility Clinic and IVF Center, UP. She has held various posts like she was past President Azamgarh Obsgani Society ISAR. She was a National Executive Committee member ISPAT and is a very keen academician. She has to her credit various awards like Golden Aim, the Most Trusted IVF Doctor Award, Dainik Jagran Women of Substance Award, IMA State Award twice. We welcome you, ma'am, to chair the session.
Thank
Next,
you.
thank you, ma'am. Next, we have Dr. Nivedita Shetty, ma'am. Madam is presently chairperson of Karnataka chapter of ISAR. She is also director of IVF unit Manipal Hospital, Mysore. She has been and practicing infertility for more than 2 decades. She has contributed various chapters in textbooks of infertility. We welcome you, ma'am, to chair the session.
Thank you, Purva. Thank you.
Next, we have Dr. Ashwini GB, ma'am. Madam is not only doctor but a teacher, chief embryologist, fertility specialist, and scientific director at Aspire Fertility Center. She is also founder of the same. She has been awarded various awards like Dr. Kumud Tapaskar Research Award, SR Rising Star Award. She has been invited as guest in various TV programs for spreading awareness on fertility. We welcome you, ma'am, to chair the session. Now I hand over the session to our chairperson to introduce our speaker, who is none other than Dr. Jatin Shah, sir.
Seema,
Hello.
able.
Hello.
Dr. Priyanka, can we have the CV of Dr.
Can we
Jatin?
have the CV of Dr. Jatin Shah, please?
Yeah, ma'am. Just a second. Syed is actually working on it.
Priyanka, we are having a certain lag in the appearance of
Yeah,
this. Can we work out,
yeah, definitely, ma'am. I will do that.
So it's a proud privilege to introduce my dear friend Dr. Jatin Shah. And can I have his CV, please?
Ma'am, just a moment.
Dr. Priyanka, if there is problem, then I can share
Yeah,
from
please,
my.
that would be help. Wait 1 second.
Yeah.
Mhm.
we got it. Yeah,
Yeah,
yeah.
yeah.
So, Dr. Jatin Shah, a topper throughout, an excellent IVF specialist, singer, dancer, speaker, we all know, is specialist director Mumbai Fertility Clinic and IVF Center, and he established more than 20,000 successful IVF pregnancies over the past 30 years. Many VIPs and celebrities included. Helped establish the first IVF ICSI pregnancy in UP and Kerala state, co-authored book Photographic Atlas of Gynecological and Obstetric Operative Techniques, awarded for best paper presentation in National Foxy Conference way back in 1995, and Young Personality of the Year in 2003. Dr. Jatin has pioneered the setting up of IVF centers in Kochi, Agra, Madurai, Erode, Chennai, and Pune. More than 500 national and international presentations, guest lectures, keynote addresses, and orations. Dr. Jatin Shah is founder member of Asia Pacific Initiative Aspire for Reproductive Endocrinology, and numerous publications in journals and texts are to his credit. I will give the stage to my friend Dr. Jatin for talking about ovulation, induction, and different spectrum. Welcome, Dr. Jatin.
Thank you so much, dearest Seema, dearest Monica, all the dignitaries in the faculty.
Welcome,
My
Jatin
dear
sir.
friends.
Welcome, sir.
Hi,
Pranam, sir.
Randir sir. Pranam,
Thanks.
pranam, pranam. And
Hi, Randeep.
sorry, who's Dr. Asha Bakshi, of course, my distinguished co-speakers, Sujata, Madhuri, all the panelists, all the young Turks. Special shout out, of course, to Monica. And as Asha correctly said, you can never refuse an invitation from her because everything she organizes is so super and so excellent and fantastic. And so also the young brigade now, Garima, Manisha, all of them for this invitation and for having me here today. Now, of course, the topic for today is a very important one because it affects all our practices. And I'll just share my slides. And more often than not, it's quite taken for granted. So we need to be, as Kundan pointed out, that we can't have just one protocol for each and every patient. We need to be highly individualized in our approach, not only to stimulating the ovaries, but also in how we are doing our embryo transfers. Should we be doing freeze-all or should we do fresh? Should we do HRT cycles or should we do natural cycles? Should we just stick to the conventional short antagonist with a fixed day start antagonist protocol for all patients? Should we be using only REC FSH for PCO patients and so on? And there are so many topics and areas that we need to touch in the next half an hour. So, of course, we are all standing here thanks to a life-changing event that occurred at the stroke of midnight, 25th of July, 1978, and which is why all of us have all these fantastic societies today of the wonderful world of IVF. When Robert Edwards, Patrick Steptoe, and Jean Purdy gave us the world's first IVF baby. The reason I put this slide is because I really relate with their kind of practice, and you must go and watch the movie Joy on Netflix. And if you remember, the first baby, Louis Braun, was born in a natural cycle IVF. So there was no stimulation. She was patient number 270 or 280 when they finally achieved success. At that time, about 35 years ago, when I just started my IVF practice, we had, of course, come to know that ovarian stimulation is important, that just one oocyte is not only not sufficient, but it's also very difficult to time the retrieval to get one single mature oocyte. And at that time, fortunately or unfortunately, we had only three molecules available to us. One was a GnRH agonist called buserelin acetate, which we used to buy in the gray market. It was marketed by Hex Germany. Then we had metrodin, which was simple 75 IU ampules of pure urinary FSH. And we had Pergonal, which was urinary HMG, again in ampules of 75. And we had a very simple protocol. Everybody was on the long agonist down regulation. If she was supposed or expected to be a good responder, the dose would be M2P1, which meant 225 of FSH and 75 LH. And if she was expected to be a poor responder, the dose would be M3P2, which meant 375 of FSH and 150 of LH. And then came the days of purifying urinary FSH and telling us that there's too much batch-to-batch variation and urinary contaminants and we need HP. And then, of course, came the recombinants. Then came recombinant LH, then came HPHMG, then came long-acting FSH. And today we've turned a full circle of ovarian stimulation back to being recommended that we must use some amount of LH right from the beginning. So 2:1, 3:1 ratios, FSH and LH from the beginning are now quite standard practice. So to understand ovarian stimulation properly, you first need to understand why getting every extra oocyte is so important, and which brings us to the importance of oocyte numbers. As Shims showed in 2020, to get one top quality embryo, you need at least 3 metaphase 2 mature oocytes. And does every extra oocyte really count in terms of live birth rates? You can see that with every extra oocyte that you get, you will have an increase which is significant in the live birth rate. So with 4% for one oocyte, you jump up to 16% if you are to retrieve 4 oocytes for a given patient. What about oocyte competence? And remember that by competence, we don't only mean genetic competency, like a lot of us have started misunderstanding and promoting PGTs left, right, center to our patients. You have to remember that if a pregnancy is considered as 100%, the sperm probably contributes 10%, the uterus and the blood flow contributes 10%, but the oocyte contributes almost 80% of a successful IVF live birth. So that brings us to categorizing the response and to help us decide that whether a patient is going to be a normal responder, a poor responder, or a high responder. We have to take into account age, previous response, BMI, AMH, AFC, whether she has endometriosis or PCOS. But the most important of all these 6, if you ask me, is if she has had a previous IVF cycle. And this is where we need to analyze in detail what exactly went wrong with her previous cycle. What was the protocol used? Was it the standard antagonist protocol? Did they use just REC FSH? Did they add HMG from day 7, which so many are used to be doing? What was the trigger given? Was the trigger given a day early or late? What were the follicular sizes on the day of trigger, and so on? And therefore, if you analyze all this, you would realize that just as Zabaleta proved in 2023 that if you have a previous IVF cycle being done, then that is the most important predictor of what protocol you should use, what dosage of FSH and HMG should you use, and what kind of a transfer should you do. But of course, if you don't have a previous IVF cycle having been done, then you have to rely on age, AMH, and AFC. Now, what is the aim of ovarian stimulation? Our main aim today is that you don't want to convert a normal responder into an unexpected poor responder. And these two groups are our common groups. You have Poseidon 1 and 2. These are young and old patients who came to you with a normal AMH and normal AFC. You thought that this so-and-so dose was adequate for them. But when you go through your stimulation, you just don't get enough oocytes. You either get less than 4, which puts them in subgroup 1A, or you get 4 to 9, which puts them in subgroup B. And then, of course, you have your Poseidons 3 and 4. This is young and old patients who have come to you with a low MH, and you are fully prepared that they are not going to respond well. So you are forewarned as to what should be the best protocol and best dose for this particular patient to help you get a good crop of top quality embryos. And I'm sure all of you agree that our greatest percentage of patients today is the Poseidon 3, that is young patients who are flooding in with very low AMH levels, low AFCs, and poor ovarian reserve. So when we talk of individualizing IVF, you need to remember that the commonest cause of iatrogenically creating a Poseidon 1 or 2 in a potential normal responder, number 1, low starting dose of gonadotropin. She needed 300, but you gave her 150. The presence of genetic factors such as polymorphisms. We know that 10% of patients might be carriers of genetic polymorphisms. Number 3, which is top of the list actually, and the most important, especially with the new short antagonist protocol that we all commonly use, and that is follicular asynchrony. And fourth is the type of trigger that we use to finally get good meiotic maturation and a group crop of metaphase 2s. But besides the Poseidon, we now understand the pathophysiology of poor responders a bit better, and we know that there are actually 4 different stages of diminished ovarian reserve, which would explain some of the unpredictable scenarios that you see when you do ovarian stimulation. So of course, since we have only 30 minutes today, we will focus on the 2 important ones. One is the stage of desynchronized cycle. And what does this mean? She has a low AMH, she has a normal FSH, she has high E2 on day 2. Now, high E2 on day 2 is the clue that the dominant follicle has already been selected in the luteal phase of the previous cycle. Her follicles will grow beyond 18 millimeters in diameter. And because she has completed a part of her follicular phase in the late luteal phase, she will have a short cycle length. So be wary of this patient, because if you start her stimulation on day 2, you will end up with one follicle of 16 or 17 on day 7, and all the others lagging behind at 10 or 12, giving you a very asynchronous cohort and a very, very poor retrieval of mature oocytes. Number 3, a lot of you must have experienced cases where you said, yesterday I scanned her, she was 15, 16 mm. I had added the antagonist at the right time. I thought she will be ready for trigger today or tomorrow, but today when she came in, the follicle has already ruptured. So these are the classical stage 3 patients who have pathological premature LH rises and surges. They have low AMH, they will have high FSH, they will have a normal E2, but they have a tendency to a premature LH rise and rupture of the follicles at a smaller size. And because of a short follicular phase, they too will have a short cycle length. So whenever a patient tells you that the cycle length is 20 to 23 days, and this is history often taken by the junior doctor and very often missed by the senior consultant when you're reviewing the papers, is a very big clue that she is not going to respond well with the short antagonist protocol. Why not look at Indian data? And we keep following the Western data that is usually for white Caucasian women, where they show that even 150 should just be your starting dose. But as we have a wonderful study here by Padma Rekha Jirge and Fadi Sharara from 2022, that for predicted normal responders in Indian population, 200 or rather 225 IU should be your starting dose across all spectrums, and not 100 or 150 as commonly recommended in Western literature. Now, that doesn't mean that you go to 300 or 450, because there is no difference beyond 225, and there is no advantage in giving 300 to a predicted normal responder. So 225 should be your minimum starting dose across all spectrums. Very important that if she is a predicted poor responder, Poseidon 3 and 4, please don't go ballistic with your doses. Please remember that higher starting doses of gonadotropins are not associated with increased oocyte retrieval in patients with low and intermediate M2 predictions. So we must avoid unnecessary increase in medication. And I'm also going to show you some newer advances where we know that very high levels of FSH might be detrimental to the final outcome of the number of oocytes and embryos. Just one slide on polymorphisms. Of course, we know that patients who are homozygous for the serine require more gonadotropins. They have longer stimulation time. They have higher basal FSH and lower E2 compared to the normal aspergine counterparts. And there are also some patients who have a variant of the beta subunit of the LH gene who also not only just need a slightly higher dose of stimulation, but also need LH right from the beginning. And these are the classic patients who we label as hyporesponders, where the follicles are stagnant at 12 or 13 mm for 3 or 4 days. Despite you increasing the FSH doses, you need to add 150 of LH for them so that you counter the adverse effects of this beta subunit variant. But the most important factor number 3, and that was asynchrony, can be avoided to some extent in antagonist protocols by simply following one of these 4 methods. So either you use luteal estradiol valerate 4 milligrams a day from day 25, and the beauty of 4 milligrams is that it will prevent that dominant follicle from being selected in the late luteal phase, and it will at the same time not inhibit menstruation. So she will menstruate at a regular time. You continue estradiol valerate, say she comes to you on a Monday, you don't want to begin stimulation till Friday. You just continue estradiol valerate till Thursday. Bleeding will stop, triple line will form, but no dominant follicle will be recruited. So then when you begin stimulation from Friday, you get a uniform cohort of follicles. You can use norethisterone, you can use GnRH antagonist on days 2, 3, 4 if you just need to tide over a weekend for a conference trip or a short vacation. You just have to give her the antagonist on days 2, 3, and 4. This especially works well if you see a dominant follicle on day 2. You give her the antagonist for 3 days. When she comes back on day 5, you will not see the dominant follicle. Now, when you begin stimulation, you will get your uniform cohort as you want it. OC pills, please avoid because you have enough other methods of doing a good pre-treatment. But if at all you have to give, start from day 2, give it just for about 10 to 12 days. Try to stop on a Sunday, give a mandatory 5 to 7 day washout period, and then begin your stimulation. And some of you might argue that why does he always say don't use OC pills when in fact every clinic in the United States uses birth control pill mandatorily for each and every patient because the doctors do not work from Friday afternoon to Sunday morning in most of the IVF centers there. But to counter this, remember also that don't just read the pre-treatment part, read the full paper, that what do they then use for stimulation. And all ART clinics in the US follow this up by starting stimulation with a combination of REC-FSH and HP-HMG. So to counter the over-suppressive effects of the birth control pill, you must begin LH right from the beginning of stimulation if you are using OC pills for pre-treatment. Otherwise, please do not use the OC pill. And of course, the 5-day washout period is mandatory to make sure that you don't have any adverse effects of the birth control pill which are carried forward. But coming to the main point, what is the best way to achieve follicular synchrony, especially in normal responders who don't have very high AMH levels or who have not responded well in the past with the short antagonist protocol, or where you know that you are dealing with a Poseidon 1, 2, 3, 4, is definitely the long agonist because it completely eliminates the stage 2 and stage 3, which I described of the diminished ovarian reserve. So you will eliminate desynchronized follicles and you will 100% prevent any kind of premature LH surges. And therefore, maybe we need to have individualization in selecting the long agonist protocol for poor responders. And there are so many benefits. One, of course, you have complete and perfect synchrony. You have higher number of oocytes and embryos because of this wonderful synchrony. There is no selection of dominant follicles in the late luteal phase, no premature LH surges. You have better quality oocytes with fewer cytoplasmic irregularities. You have more zygotes with better 2PN morphology. And the most important, since we are now in a time where we need to go back to doing more and more fresh transfers and not doing freeze-all for all, especially since we are aware that the functioning corpus luteum is very important in early pregnancy, remember that there are enough studies to show that the endometrial receptivity is much better in an agonist protocol as compared to the antagonist. What is the evidence that I have to back this up? And of course, this is a very recent article from 2024, where they compared the agonist versus the antagonist in the first IVF cycle of a patient. Clearly, greater number of oocytes retrieved and a 7% higher ongoing pregnancy and live birth rate in the agonist versus the antagonist group. And you have Huang study from 2018 who categorized the various Poseidon groups and clearly showed that in your young patients with low AMH, which is the bulk of our practice, Poseidon group 3, you can see the live birth rate with the agonist 31% as against 16.7% with the antagonist. One more study by Liu in 2020 shows even Poseidon 4, where the AMH is not below 0.7, does give higher cumulative live birth rates than using conventional antagonist protocol. And finally, you have this Cochrane analysis from 2025, again renewing interest in the agonist protocol and showing evidence that the long protocol may improve overall clinical pregnancy rates. If you want to have the advantages of both, and is some protocol which was very popular a few years ago, is the stop agonist antagonist protocol. So you begin her on mid-luteal agonist, wait for down regulation. Then once she has menstruated, you give her a washout time of 2 days. Then begin your gonadotropins without, of course, continuing the agonist. Then add your antagonist at 14 millimeters. You can see here the agonist. Then she menstruates. Then you stop the agonist 2 days. Then begin your gonadotropin. Then add your antagonist at 14 millimeters in diameter. Now you have the flexibility of using both the HCG or the agonist or a dual trigger. You also have the flexibility of doing a fresh transfer if you give an HCG trigger, and you also have beautiful follicular synchrony, and you do not have any premature LH surges. So better programming, higher M2 yield, can use dual trigger, higher number of top quality embryos, complete abolition of the premature LH surge, and you don't need very high exogenous gonadotropin doses, which is one of the common criticism factors for the long agonist protocol. Why are pregnancy rates lower with the antagonist in fresh transfer cycles? Of course, we'll come to that. One, I told you earlier, as you can see with the agonist, you have better oocytes, you have better zygotes, and a higher clinical pregnancy rate up from 28 to 38%. LH surges prior to initiation of the antagonist can occur in 8% of fixed start antagonist cycles. And this is especially higher with flexible start. For example, in a PCO, if you wait for 14 millimeters when you suddenly have 20-30 follicles, the premature LH surges might have already started, which will then not be optimal for getting a good harvest of metaphase 2s. Synchrony, I told you, is the third most important reason why agonist has better pregnancy rates, because you don't have any large forerunners, as you often see if you have started stimulation on day 2 or day 3 in the antagonist cycle. But most importantly, what about endometrial receptivity? You can see with the antagonist, you have a significantly lower Hoxaten expression in endometrial stromal cells, and this explains the lower pregnancy rates with fresh embryo transfer. Moving on to the trigger, of course, we know that the best trigger and the most physiological trigger, of course, is the agonist trigger. Because if you simply go back to Spiroff and look at the physiology of the menstrual cycle, you will see that you have surges of both FSH and LH at the mid-cycle, and it is not only a LH peak. So when we give an HCG trigger, we are only simulating LH. We are not simulating FSH, and that is why you may not have the same effect as an agonist trigger in terms of conversion to metaphase 2 oocytes. Of course, the agonist trigger has a very short half-life, so there is abrupt luteolysis. Corpora lutea are deficient, and therefore fresh transfer rates are not too good. And that is why the dual trigger came in to get the advantages of both. And you can see here when you add HCG 6500 and the agonist trigger, your live birth rate goes up from 14.5 to almost 27% in patients with a diminished ovarian reserve. So to answer the question, is the agonist trigger better? The best way, of course, is to see what is the cumulative live birth rate of the frozen embryos from either trigger. And you can see the cumulative live birth rate from agonist trigger generated embryos much higher than from HCG generated triggered embryos. Adjuvants for Poseidon 3 and 4, of course, that can be a lecture in itself, but evidence based as of today, we know androgens work. Ubiquinol, the active form of coenzyme Q10, works, and growth hormone might be promising in the future. So we have a lot of articles showing that coenzyme Q for 60 days prior to IVF is recommended, especially for Poseidon 3 and 4. And sometimes maybe a combination of ubiquinol, resveratrol might work better. And these are some of the evidence-based papers that we have suggesting that what should you select, because you have such a huge range of products with different combinations available to us today that we don't really know which one is the better and which one is worse. So just look out for whether they have some of these components besides ubiquinol and resveratrol. A little bit more on androgens, of course, Polysor showed in 2020 higher number of oocytes, better live birth rates with testosterone. And simply put, what I do in practice is give it for 21 days. So we start from day 6 in the preceding cycle. By the time she completes 21 days, she usually comes to you on day 1 or day 2 of her menses, which is when you want to begin your stimulation cycle. How high should you go? Now remember, for predicted poor responders, there are numerous studies showing, you can see here different doses of REC-FSH as a fixed daily dose calculated by fill by mass, and you can see there is no difference in cumulative live birth rate. So it is time to stop using high FSH doses in predicted low responders. LH supplementation, of course, we know that it is almost mandatory now to give it to most of the women above the age of 35 because they have less functional LH receptors and low levels of circulating androgens. All hyporesponders, if the past cycle shows that a follicular phase went on for 15, 18, 20 days, please begin LH right from day 1. Patients with hypogonadotropic hypogonadism will need 300 IU of FSH and LH for a good response right from the beginning. All Poseidon groups without any question, and there is always a question mark as to whether PCOs also need some amount of LH. So recent evidence, again, you can see here a study combining REC-FSH with 150 IU of HPHMG versus REC-FSH alone, and the combination gave you higher estradiol levels, better fertilization rates, and more top quality blastocysts available for transfer. Now, this is a very, very important slide because we have a tendency to start with FSH, and for some reason only well known to us that maybe we are adding the antagonist, or maybe on day 7 she needs more LH, or whatever we think, we switch to HMG. Remember, early follicular HMG means if you start right from the beginning versus mid follicular HMG, live birth rate almost halves. So you have 22% when you start early follicular HMG as against 12% with mid follicular addition as an afterthought from day 7, and this is especially for Poseidon's group 3 and 4. And then, of course, we had the Megaset HR trial, which compared REC-FSH and HPHMG for high responders and poor for our PCOS patients. Our main problem, of course, in PCOS has always been early pregnancy losses, and you can see HPHMG, the pregnancy loss went down from 24% to about 14%. When they looked at the FET outcomes, again, they found the same reduction. And mind you, these were FETs done using euploid PGT tested embryos. So how then do you explain such a high incidence of early miscarriages with the REC-FSH? So probably there is something in HCG-driven LH activity which helps to improve mitochondrial, cytoplasmic, and other competent factors of the oocyte besides just genetic competency. Dual stimulation, of course, all of us just swallowed it left, right, center. But there is a twist in the tail because, you know, when we did our conventional dual stimulation, we always give an agonist trigger for follicular phase stimulation, but the patient would menstruate within 2 or 3 days, or sometimes we would prevent menstruation by continuing giving her medroxy or something like that. And then we used to start the so-called luteal phase stimulation. On the same time, if you go back to basic physiology, we also know what I just said earlier, that the agonist trigger will be associated with premature luteolysis. And that is why she menstruates so soon. And yet we didn't get the clue that this is not LPS. If you were to do a estradiol progesterone estimation during the first or second day of that menstruation, the levels would be like that of a follicular phase and not show high progesterone as a luteal phase. So what we were doing for almost 3 or 4 years after Ubaldi's first paper was just 2 consecutive follicular phase stimulations and calling it LPS and FPS. And then, of course, because we couldn't do fresh transfers, we now have more and more concerns about macrosomic fetuses and PIH. So the correct way to do dual stimulation is, of course, to begin the first stimulation in the luteal phase. So as soon as you document ovulation, you then begin your FSH or HMG administration, add the antagonist at 14 millimeters, give an agonist trigger, do your retrieval. She will menstruate in 2 or 3 days. Then begin your classical follicular phase stimulation, add your antagonist. This time give an HCG trigger so that you can do a fresh embryo transfer and use whichever embryos were of better quality to give her the best outcome. So this is the way actual dual stimulation needs to be done, so that you are in fact doing a correct luteal phase stimulation and not two back-to-back follicular phase stimulations. A few laboratory aspects for poor responders, of course. Please do not do ICSI for all. Just because she has 3 oocytes or just because she is 37 years old is by no means an indication for preferring ICSI over IVF. We know that when you do ICSI in the absence of a male factor, and this is a large study of 200,000 infants followed up at Johns Hopkins, they showed a risk of birth defect increase by 30%. What really works well in the laboratory for Poseidon 4 is to do oocyte activation with calcium ionophore media. And we know that will give you a 3-fold increase in the probability of getting a top quality embryo. And finally, of course, everyone's favorite fallback tool and the best or misused, overused, abused add-on that we have in IVF probably is PGT. And to put that to rest, we now have a wonderful paper, because we have a tendency to tell a 40-year-old or a patient who has had 2 implantation failures that, oh, now we must think of doing PGTA for you. And then we put in a euploid blastocyst, and still she doesn't get pregnant, or still she ends up with an early miscarriage. And I'm sure it's so frustrating then to answer the patient whom you had assured that we will put in a euploid blastocyst so that you don't miscarry or you will have a higher pregnancy rate, and then we still have a dismal outcome. So a wonderful large study by Laura Renzi, Carlo Elvigi, and Ubaldi. Why do euploid blastocysts fail to implant or again miscarry? So they analyzed 413 papers on PGT, 1,600 items, taking into account embryonic, maternal, paternal, clinical, and laboratory factors, and clearly proved that euploid blastocyst transfer cannot compensate for advanced maternal age, for recurrent implantation failures, and if the initial quality of the embryo morphologically was not good. So morphologic assessment of the embryo is still the gold standard of assuring embryo quality rather than just proving genetic competency. So please be careful with PGTA counseling. And also, as per the ART Act, we can't do PGT for every patient. So we need to really be balanced where PGT is required and not required. And of course, we now have some new things for the poor responder, some very new radical concept which shows that excessive FSH may not be good for some patients. And this is the concept of term stimulation, where, just like we have a full-term pregnancy of 9 months and a 28 or a 30-weeker is known as a preterm pregnancy, so also the normal follicular phase in a normal menstrual cycle is about 17 days. But in IVF, classically, for the last 3 to 4 decades, we truncate this follicular phase by triggering on day 10 or day 11. So is this one of the reasons why some of the poor responders, the eggs do not get the full term of maturation that they require because they are poor responders, because the eggs are not as strong as younger eggs? And should we be rethinking our approach and individualizing our approach for these patients? So how is it done? Of course, you have to use the agonist cycle. You can see her baseline FSH is 8.9. So target serum FSH is put to about double. So double means she should be around 18. So you put this target between 15 and 20. And you can see they started with 300 IU. Then they checked after 4 days, it had gone about 20. So you reduce the dose to 225. Again, you check 17.2. Again, you check 14.75. So again, you step up to 300. But the point is you go the full 17 days. You ignore the follicular diameters totally, and you will see on triggering day, she has follicles as big as 28, 25, 24 as would be expected. And all of us would wonder, how can this even work? Would you even get a single oocyte? But look at her previous response. The same patient, 42-year-old, first conventional stimulation, she consumed 3000 IU of FSH, got only one abnormal embryo on PGTA. Second conventional stimulation, 10 days of stimulation, again only one abnormal embryo. With term stimulation, the same patient for the first time, 17 days of stimulation with maintenance of FSH levels at a critical level. Total IU consumed marginally higher at 4200, for the first time had a genetically normal embryo. So also this patient, you can see again, she had a baseline of 2.8. So they started with 300, then they dropped down the dose to maintain at double, that is between 5 and 10. So you can see 150 was adequate. 1 or 2 days they coasted, they did not give any FSH. Full 17-day stimulation, again triggering at very large follicular sizes. And you can see first cycle, day 3 embryos of very poor quality. Second cycle, no development. This is both with conventional stimulation. And when she went to the full 17 days, she got 5 top quality blastocysts. So there is something hidden here, something we need to delve into more. Of course, we are expecting some larger studies in the next 6 months or so. And that might change along with, help from AI-based algorithms that maybe we've been triggering wrongly for a lot of our poor responders. And maybe this is the way we should go forward and try and get the best outcome for them. So of course, how do you prevent LH-independent follicular luteinization is usually by giving diclofenac, vaginal suppositories 50 milligrams twice a day. And as I told you earlier, that some patients, so right now it is restricted to patients who will just not give you even one good embryo. And it concludes that the adverse effect of FSH, if it exists, is mediated not by the total amount that you use in a cycle, but by its peak concentration on a daily basis. So this is, of course, the ideal treatment strategy. 60 days of pre-treatment, testosterone gel. My first choice protocol is the long agonist. The trick is to begin with HMG. Don't start with REC FSH in a long agonist because you will not get a good response. Second cycle, short antagonist with mandatory pre-treatment. Again, beginning with a combination of FSH-LH. Lots of fresh embryo transfers. If your progesterone levels are normal on the day of HCG, you have two top quality embryos and an endometrium which is nice and triple line and more than 7 to 8 millimeters. You can definitely do fresh embryo transfer for these patients. Finally, of course, not much for the high responders, but there is one new advance here again in delaying the triggering to get a better outcome. We know that in PCO, again, the miscarriages are not because of genetic anomalies always, and PGT is not usually the answer. More often than not, these miscarriages are because of mitochondrial defects. So what are the challenges? Of course, pre-IVF management, we know melatonin is being promoted more and more. Myoinositol with melatonin, with folic acid and vitamin D supplementation seems to be the right kind of pre-treatment that these patients need. For a couple of months, you can see the myoinositol group did much better. Shorter duration of stimulation, more M2s, better fertilization rates, and so on. And of course, metformin now is no longer recommended empirically for every PCOS patient that walks in. And we also now have research that liraglutide, a GLP-1 receptor agonist in combination with metformin, gave a higher cumulative pregnancy rate over 12 months in women with PCOS undergoing IVF. So a lot of exciting advances expected in the field of PCOS as well. And of course, this was one of the studies from our country here comparing myoinositol with metformin and again showing myoinositol having a higher cumulative pregnancy rate at 43% versus 22% with just metformin. So of course, we all know it's a no-brainer. You have to use the antagonist protocol. You cannot dare use an agonist protocol for a high responder. You don't want your sleepless nights with OHSS. Most often you have to use the agonist trigger again to prevent the OHSS, and most often you have to do vitrification with freezol because the agonist trigger will not have sufficient corpora lutea to give you a good secretory endometrium. Again, do not use the OC pill. You can see studies here clearly showing that if you start in a spontaneous menses, you have higher pregnancy rates. So many studies over the years showing the adverse effects of OC pills as pre-treatment in PCOS patients. And if some of you are worried about high LH levels on day 2, which is why you want to give them an OC pill, then we have a large study here from 2024 comparing two groups with high LH on day 2. One where the OC pill was given, there was a 7-day washout period. The second where no OC pill was given, and you can clearly see high LH levels on day 2 did not have any negative impact on embryo quality. So lowering this LH level with birth control before ovarian stimulation is totally unnecessary. And the lower the LH levels because of your OC pill pre-treatment, your agonist trigger will be that much ineffective because for the agonist trigger to work, you need a very good stock of endogenous FSH and LH. And here you can see the greater the suppression of LH, which is likely with prolonged birth control pre-treatment, almost 50% of your cycles will not give you an optimal response. Finally, of course, we now have PPOS. So what is the status of PPOS compared to the agonist? You get most of the advantages. but you reduce your total gonadotropin dose because the PPOS will not have excessive suppression of the hypothalamo-pituitary ovarian axis as which you will expect with the agonist. What about poor responders? Of course, we had polysosis study in 2024 across all spectrums, showing there was no compromise in embryo ploidy rate. But again, when we talk of individualization, what about women above the age of 38? You know, when you're dealing with eggs above the age of 35, 37, 38, they are not the same as young eggs, but it doesn't mean they can't give you a healthy live birth. So you have to take some precautions with these eggs. And you can see here, as this study showed, that euploidy rates reduce in women above the age about 38 when you use PPOS as compared to conventional antagonists. So from 26.7% euploidy, you drop down to 5% because these eggs at an advanced age cannot take the insult of synthetic progesterones, which could reduce the number of antral follicles, oocyte health, meiosis, and cytoplasmic maturation. So this is a further level of individualization that you need, that you cannot use anything in IVF for everybody. You have to know for whom, what do you use to give her the perfect tailor-made IVF cycle. Is PPOS better than antagonists, or is it just reducing the number of injections? Chen's wonderful study in 2022, clinical pregnancy rate higher with PPOS generated embryos as compared to short antagonist generated embryos. Dihydrogesterone, yes, that too can be used instead of medroxyprogesterone acetate. You can see clinical pregnancy rates equivalent if you just give 20 milligrams of dihydrogesterone from day 2 as compared to 10 milligrams of MPA from day 2. You also have now the option of doing a flexible start. If you don't want over suppression from day 2 of the number of follicles to be recruited, you can begin as a flexible start from day 6 or day 7 as you do with the antagonist. And whether you use MPA 10, 2.5, dihydrogesterone 20, 200 or 100 of MVP, all are equivalent. And there is a recent study which says that even one capsule of 200 milligrams MVP orally suffices to completely eliminate the premature LH surge and could therefore be the treatment of choice for all your freeze-all cycles. And to end, of course, what is this delayed triggering in PCO patients? Primarily, it was presented by Itakura at IFS and ISAR in the last year at our Indian centers. I don't know how many of you attended it, but sounds very fascinating. Again, focused on just the last problem that we have with PCO, and that is the problem of early miscarriages. So very simply put, he begins REC FSH from the beginning, day 2, switches completely to HMG 150 from day 7, starts the antagonist not at 14 mm but at 18 millimeters, gives the agonist trigger not at 17, 18 millimeters, but when the largest follicle is more than 24 millimeters. And with this, he found the miscarriage rate reduced from 25, 30, 30 to 19.4%. Live birth rate increased from 18, 27, 25 to 36%, and the cumulative live birth rate up from 30, 40 with conventional to 57%. So there seems to be some merit here again that delayed triggering may be useful for some PCO patients, especially the ones with very high AMH levels, and maybe we need to do a few more studies of our own to find out if it's true. So this he compared the agonist versus antag-HCG versus antag-agonist, and he found that this modified protocol gave much better outcomes. So of course, ESHRE guidelines for high responders, just as a recap, OC pills not recommended, antagonist obviously, addition of CC letrozole not really required, RFSH, HMG are equally recommended, mid-cycle adjustments of doses don't work, routine adjuvant metformin not recommended, no need to do any E2 measurements, whether the E2 is 5,000 or 10,000 or 20,000, whether you have 30, 40, 50 or 100 follicles. When you're giving an agonist trigger, you are 100% sure you will not have hyperstimulation. So please don't give her any prophylactic cabergolines or albumins. You must use the agonist trigger and you must use the freeze-all strategy. So thank you, Perfection Fertisphere. Thank you, Isar. Thank you, Monica. Thank you, Garima. And thank you, everybody, for this wonderful session. Thank you so much.
Jatin sir, we want to give you a standing ovation if we could.
If you could stand, yes. Brilliant, yes.
Really brilliant, brilliant.
Thank
Too
you, thank you, thank you.
And I listen to your talk, I think once a year, listen to you speak on ovarian stimulation, and every time you update it till the last year. You keep updating the slides, and it's absolutely fascinating. Comments from chairpersons, please, Nivedita. And
Yes, of course.
I
I'd
see.
like to agree with you. Of course, Monica, every time I listen to Dr. Jatin, it's an additional point. I thought, ovarian stimulation, we probably know everything, but no, again, comes up with something new. I hadn't heard of term stimulation, the delayed trigger in PCOS. I mean, more and more fascinating things. Ovarian stimulation, it's getting more and more fascinating nowadays. Thank you, sir. Thank you for an insightful lecture. It was a real pleasure. And Monica, I'd like to thank you for making me chairperson. So I sat and listened to the entire talk word by word. Beautiful. Thank you for the wonderful experience, sir. Thank you.
Thank you so much.
Jessica, can
Thank
can
you.
we can you please take a few questions?
Yeah, sure.
Yeah, sir.
Yes.
How much of your poor responders are you putting on the long protocol
All of them, all.
practice? All
I
of them,
I showed that one slide, that is my practice slide. 2 months
right?
of pre-treatment, then first choice protocol is long agonist with HMG 300 or 450 from the beginning, no rec FSH. And if that doesn't work, then the second cycle will be a short antagonist with estradiol pre-treatment, again starting with combination FSH LH, 300 of FSH and 150 of HP HMG. So those are my most favorite protocols for poor responders. But the long agonist, hands down the winner. It's really wonderful. All of you must go back and try. I've been telling for the last 5 years, but very few people tend to switch. Probably because, a lot of the younger clinics which have started in the last 15 years or so have only heard about the antagonist protocol. So the mistake which happened is, when the antagonist protocol came as a life savior for high responders because of the flexibility of using an agonist trigger, everybody switched every patient to the antagonist. They forgot that the biggest problem was OHSS with agonist. But that means more eggs and more embryos. But isn't that what we want in poor responders? So we should have held on to those advantages for the poor responders. But it's never too late. Fine. So now we know that not to, just suddenly shift practice. Like freeze all came, everybody went to freeze all. Now again, we know let's do more and more fresh transfers. Then everybody went to HRT FETs. Now we are saying we should do more natural cycle transfers. So I think any shift should be balanced with a lot of understanding of physiology, and then only we should make changes for all patients. It's always nice to be individualized for each and every one. Like even MVP for luteal phase support. I just realized learned when I was researching for a lecture on luteal phase support that above the age of 35, vaginal absorption of microvaginal progesterone is not too good. So that is one category of patients where injectables are better than MVP. So this kind of individualization has to be there rather than giving everybody injectable, everybody vaginal, everybody dufaston. That doesn't make sense, right? So that is what the whole point should be now, because more and more centers, especially like yours, mine, who have, I think 80% of our patients are patients who have failed IVF somewhere in the world. We cannot be doing the same thing again and again.
So, sir, how much percentage of your gonadotropin you're consuming more with long protocol? I mean, this
HMG,
surface.
urinary
How,
HMG.
so, how many units you consume more because of the long protocol?
Hardly much, because it's 450 is my cap. I don't go above 450 for anybody. So 300 to 450 is the range. If she's very thin, 32, Poseidon 3, then 300 is also okay. If she's 38, a little high BMI, then maybe 450. So it fluctuates between 300 to 450 for most of them.
So, sir, it's so heartening to hear you that you are doing your fresh transfers. We also do fresh
Good.
transfers.
Very
So,
good results. Very
what is
good.
your day of transfer? What is your favorite day of transfer? Cleavage stage or blast?
My favorite first transfer is always cleavage stage. So usually it's a day 3 transfer for the first transfer. And we always keep straws in such a way that we never repeat anything. Just like I don't repeat stimulation again. If the first transfer is a day 3, the second transfer will be a blastocyst transfer. So we just keep changing that also.
So, sir, have you practiced cleavage stage single embryo transfer? Do you practice that or a double
For very
embryo?
few patients, no, the cleavage stage single transfer is usually only for someone who already has a child and is very, very particular that I don't want twins at any cost. Then we, of course, have to do a single transfer. But there I would prefer to go on to blastocyst, because it's very difficult to select one embryo from a cleavage stage group. So it's not that easy to do.
So, what is the thinnest endometrial thickness in which do you do a fresh transfer? What would be the thinnest endometrium?
No,
And you would
7 is generally the cutoff, but you have to take a history into account. What has been a previous endometrium? What was is it a structural damage? Is it a case of intrauterine adhesions where you've been operated again and again? So nowadays we are doing a lot of subendometrial hysteroscopic PRP with heartening results. We just have right now one patient who is in a 33rd week. She never had an endometrium beyond 6 mm. And even with subendometrial PRP, and she had 5 failed IVF cycles before she came to us, and we did subendometrial histoscopic PRP, and then after she was on estrogen, we did 3 intrauterine PRPs before we started progesterone. Only problem is there is a higher incidence of placenta accreta. So you need to be careful in these patients with, dense adhesions where you do all these PRPs. So pregnancies might happen, but there is a complication which can also happen. So it seems to be working well because surrogacy is so difficult. I know in MP it's a little relaxed now, but in Maharashtra we are still having a lot of problems. So we decided to, this paper was presented at ESHRE that you do one hysteroscopic subendo PRP and then you do three intrauterine PRPs and then you do the transfer. So we have just done a short series of about 20-30 patients and we seem to be quite okay with the results. So even
And
6 MMs have conceived. It's not that they don't conceive. And if you look at literature, and in fact, my lecture on transfers, embryo transfer, the first slide I show is that large Chinese study of 30,000 cycles, where they have shown a 20% live birth rate even at 5.5 mm. So, we need to take that into consideration before just canceling a cycle.
are you using, sir, activated PRP or only normal PRP?
Activated.
So that is, you do chemical activation or thermal activation, sir? How do you do?
Chemical. We use
Chemical
those
activation.
kits, yeah.
Okay, fine. Okay.
There are some proponents, Jatin sir, who speak on just intrauterine installation of PRP nowadays instead of a subendometrial injectable form. What is your opinion, sir?
No, so that is of course first choice. If it's just a borderline case, 7 mm, 8 mm, then we don't do subendometrial. So subendometrial is reserved for those who are at 6 mm or at least 2 or 3 implantation failures in the past with top quality embryos. So it's selected group. It's not for everybody. So nothing I do is for everybody. So that's why I said it's just 20 patients in the last 6 months. So it's only the really bad cases where we are trying it out right now. Otherwise, I agree with you. Intrauterine PRP is good. We have a very large study now of almost, I think, 1,000 patients which has been published, I think Chinese or probably the European study, where they have clearly shown that intrauterine PRP increases the clinical pregnancy rate to 22% in patients who have previously just failed cycles. So it seems to be working.
Any good views on GCSF? Intrauterine?
No, we used to do GCSF before PRP came, but now we switched completely to PRP. There are some centers which give subcutaneous injections of GCSF starting a day or two before transfer. So we did that for 2 or 3 patients, but not enough numbers to really talk about it.
Sir, do you practice a fresh embryo transfer with a dual trigger?
With a dual trigger, no. If it's an HCG trigger, then I will do a fresh transfer.
Okay, only with the pure HCG trigger.
Yeah.
Otherwise, dual trigger, you freeze the embryos.
Yes.
Okay, sir.
Sir, and the trigger in a long protocol, agonist protocol, are you using 2 HCGs, or recombinant HCG? What HCG are you using and what dose, sir?
Rec HCG as per BMI, if it's a thin patient, single dose is enough. If it's a heavier patient, then 2 of them. We go by BMI.
Okay,
So
sir.
very nice talk. There's one more question in the chat box, sir. Your experience on oral antagonist. Have you tried this?
No, there's no application in IVF according to me, because if it is just to replace injections, then PPOS is a cheaper alternative. Why would I spend so much money on elagolix, right?
Yeah.
So the company keeps coming and telling me that please give a talk, please give a talk. I said, see, first of all, there's not much literature on use in IVF for stimulation. And whatever literature is there, all endometriosis, adenomyosis, so you should get the surgeons to talk about it. And if it is just to replace injections, it makes no sense whatsoever. Because the
We
tablet
have a
of
cheaper
2.5 Meprate is much, or even dydrogesterone 20 milligrams a day is more economical than elagolix to be given.
How,
sir,
how
I
do
don't
you
see any
decide on the
application. I don't
pre-treatment
see
drugs?
any application.
Yeah, please continue, Ashwini.
Sorry.
Yes. What is your preference for pre-treatment for having a good cohort? That's the next one that's come up.
No, so agonist is number 1 on the list. There is no better pre-treatment to get a uniform cohort. Number 2, if you still want to use antagonist protocol, then estradiol, luteal estradiol works well because it takes care of the desynchronized stage. It takes care of pathologic premature LH surges to some extent, not completely, but definitely desynchronization is less. So luteal estradiol very easy to do because any of your assistants, anybody, if you keep one thing, now it's easier for them to do. So any patient you are going to call on day 2, you just have to tell them start estradiol valorate day 25 and walk in on day 2, 3, 4. You can even start stimulation as late at day 8. So that is the beauty of this, that you don't waste the month. Even if she comes later than day 2, day 3, you will not have a dominant follicle and you have perfect synchrony. So luteal estradiol, in my experience, I've been using it for 8-10 years. It works the best.
I think you used to tell
Yeah,
us about luteal phase. The method of cycle programming with estrogen or progesterone way back when we had ESHRE in Portugal, sir.
Yeah,
You were
it was 15 years ago. Yeah, almost.
yes, yes. So, I mean, you've been talking about it. And sir, term stimulation, have you started using that?
No, I want to, but I just read about it. It's only 2 case reports. I'm just waiting. Maybe one more paper gets published, then we'll
It
try.
sounds a little
Definitely try.
scary, sir. That
Yeah,
is
if
for
the
Yeah,
sure.
patient is counseled that, okay, I'm doing something new for you, it's worth it. Should be worth it.
Yes.
it's doable. I mean, the pregnancy rates are so encouraging that,
Yeah,
sir, I
because the authors have already done 26 patients. So they're waiting for 100 to publish a good paper.
thank you
Yeah,
so
we
much.
see that straw colored fluid, no, sir. Whenever the follicular sizes go beyond 22
So
or
that's why
23.
diclofenac is the key. You have to give diclofenac to prevent non-LH dependent premature
Luteinization.
luteinization. Yeah.
Yeah.
Thank you so much, Jatin sir. And
Thank
we
you,
are,
Thank you,
Monica.
sir.
Thank you.
Thank you.
it's like ye dil mange more. We are looking for more lectures from you. Kindly do oblige us in the future. We want to listen to your
Anytime, anytime.
lectures on luteal phase support. We want to listen to your embryo transfer lectures. And definitely, sir, this has been one of the best sessions that Perfection has ever seen. Thank
Oh,
you so
thank you.
much. Thank you. Thank you, sir.
Thank you
Thank you,
so
sir.
much. Thank you.
Thank you, Dr. Monica.
Thank you, Nivedita. Thank you, Ashwini. So now,
Monica ma'am, Garima here. I would just want to thank Jatin sir for accepting this invite. And I think I'm very sure, sir, just because of your name, everyone was glued to the screen.
You joined now? Good to see.
I was going through a simultaneous webinar and I then joined in.
So you'll hear me on Sunday again anyway. So.
Yes.
Okay. Thank you so much.
Thank you,
Thank
sir.
Thank you,
thank
sir.
you, Jatin sir. So, Garima, hi. Would you like to introduce Sujata, ma'am, Garima, or
Yes, I can
yeah,
do that.
yeah. So we'll just start session two. Shweta can start with the chairpersons, and then you could join in for introductions. Shweta, can you start session two, please?
Uh, Next, we have control ovarian stimulation in IUI. And we have speaker Dr. Sujata Karma, very dynamic vice president of SR. And for chairperson, we have Dr. Vidya Bhatt ma'am. Ma'am is director and considered Radhakrishna Multi-Specialty Hospital in IVF Center. And madam has held many important position in the past. Like she has been the president Kasoga in 2017 and 18, and Bangalore Society of Obs and Gynae president in 2012 and 13, joint secretary Foxy, governing council member IH, and currently she is treasurer IH. Ma'am has been awarded as Times of India Award for Excellence in Fertility Enhancing Surgeries, MedLife Asia Award Best Fertility Consultant, Golden Aim Awards Healthcare Leadership Award for Excellence and Leadership in Healthcare, Economic Times Best Endoscopic Surgeon Award, and ma'am is also doing NGO for poor women and children. We welcome you, ma'am. Next, we have Dr. Pooja Mehta, madam. Dr. Pooja Mehta, madam, is the chairperson Chandigarh chapter ISAR, and she is associated with Fortis Doom IVF Center in Fortis Hospital, Mohali, and working as senior consultant and infertility specialist in Fortis Bloom IVF Center. We welcome you, madam. Next, we have Dr. Rimni Singla, madam. Madam is Treasurer Chandigarh SR, Director Radiance Hospital and Test Tube Baby Center, and Medical Director Singla Mediclinic Laparoscopic Fertility Center. And she is Founder Secretary Mohali Obs and Gynae Society, Chairperson for Disha Women Welfare Trust, and member to various important organizations like Foxy, SR, IFS, IMS. And she has been awarded as Rashtriya Swarnim Hind Award in 2019, Best IVF Specialist at Punjab International Healthcare Award, and Indian Iconic Awards and Disha Women Award. We welcome you, madam. Over to Chairperson Dr. Garima Sharma ma'am for introduction of our speaker, Dr. Sujata Karma.
It's an absolute honor to introduce our second vice president of ISAR, a very dynamic lady in the society, Dr. Sujata Kar, madam, and truly a mentor. Can I have Madam CV, please? Madam, special area of interest we all know is the PCOS and the proteomics of male infertility and scope of stem cells in gynecology. And Madam has received 7 gold medals in MBBS, MD, credited with the first IVF baby of Eastern Orissa, first TESA, frozen embryo, and laser-assisted hatching baby of the Orissa. So Orissa has literally seen the advent and the growth of ART under the aegis of ma'am. And she has been the recipient.
Garima, I think we should stop because it's all right. And you have introduced me as the vice president, which is a big honor. And either ways, this is a little old CV to because this still says general secretary. So you've done the main thing you've told. So that's good enough. That's good enough, Garima. Thank
We
you so
welcome you,
much.
ma'am.
And you all are either ways, all of you are so close and so known for such a long time. अभी वही चीज कुछ फायदा नहीं होगा बोल मत.
So, would
Okay.
other chairpersons like to put in a word before the talk starts, before we give the stage to Sujata ma'am? And I heartily thank Sujata ma'am for accepting our invite. We have Pooja.
Thank you, Monica, for
and,
giving me
me.
this chance.
Okay, ma'am. So, thank you so
I
much.
I think we welcome Dr. Sujata Kar ma'am. I think it will be an honor to actually listen to her, especially a topic which
Thank
is
you.
really dear to all of us because we all gynaes, of course, being a IVF specialist, we are doing a lot of IUIs and all, but especially for gynaes, I think ovarian stimulation protocols and IUI is very important, which is a very topic which is very much needed, at the of the. Thank you so much, ma'am. Please welcome.
And
Yeah.
Sujata ma'am,
So
something level
yes.
1 ART clinics. Level 1 ART clinics will be totally, they would love this lecture from you.
Yeah, I let me hope so. Only I hope I don't disappoint you because I'll be speaking hardly for 15-20 minutes. It's very difficult for me. So, but then I hope it will be useful. And I remember that you told me that Jatin will be speaking overall about, different kinds of ovarian stimulation needed in IVF. So what I did is I just put 3 or 4 different case scenarios that most of us, level 1 or level 2 people see. And usually all the cases will initially start with IUI. So that is how I have covered. So I hope it will be somewhat useful for people. Okay. So thank you once again, Monica, and the whole group of Fertisphere for giving me this opportunity to speak in this interesting and about lovely names every time you find for your, webinar series. Thank you very much. So now IUI, we all know, is based on 4 pillars. Number 1 is patient selection. Number 2 is ovulation induction protocols. Number 3 is IUI setup that you have, and the total progressive motile sperm count, which is an independent predictor of IUI success. Now, ovulation induction is the one I'm going to today talk on, kind of focus on about IUI. In ovulation induction, again, we have 3 aspects. One is the technique, what ovulation induction protocols you'll be using. Then follicular imaging and monitoring of the cycle to decide when you need an IUI. And third is timing of IUI. Again, I'll only be talking about the various techniques and which patient needs what kind of ovulation induction. But ultimately, the aim of ovarian stimulation for IUI is dependent on a couple of things, like what is the patient profile, her age, her BMI, her AMH, things like that. What is the indication for IUI? That will completely decide as to what protocol you will use, the drug cost availability, the patient response, which is going to vary because each patient is different. And what we are looking for when we are doing an IUI, that we don't want more than 1 or 2 follicles. That probably we should at least reach at least an 18, 19. And E2 we don't do for IUI, but then this is the optimal level that we want. We don't want any kind of overstimulation, and we want a good receptive endometrium, which can be defined if you have a benchmark, maybe 7 to 9 millimeters, and a good morphology being trilaminar. Now, based on patient profile, a little bit of primer about how to decide which ovarian stimulation protocol. When you're doing an IUI for a male factor, let us say severe, moderate oligoteratozoospermia, or for you're doing a donor insemination. In that case, you might do it even without any stimulation. You can do it in a natural cycle. This is NIC level 1 recommendation, and this can, of course, be taken up or with a minimal stimulation. And also we should know that clomiphene and letrozole both have equal results where IUI success and ovarian stimulation success is concerned. Best is gonadotropin in low dose, which is most effective. Recombinant and urinary have the same outcomes. We all know that. Addition of agonist and antagonist, which in between was in vogue, really has no great advantage. In the era of IVF and ICSI, what is our role of IUI? Yes, it is very much there. There is a large chunk of patients who initially need to undergo these treatments. Let us say the primary conditions would be a woman who is less than 40 years, who has normal tubes, who has normal or mildly reduced male factor, has a short duration of infertility. We should try this maximum for about 4 cycles. And as we will see, usually a gonadotropin addition stimulation, there's a classical, Cochrane review that tells us that adding gonadotropin actually increases the IUI success rate. Other than that, this is a very recent 2020 publication which talks about predictive factors for intrauterine insemination outcome. Now, again, as I mentioned, total motile sperm count, independent predictor of success. High sperm DNA fragmentation. Now DNA fragmentation also is in vogue, and there was a lot of discussion about whether DNA fragmentation can help you decide whether this patient is for IUI or should undergo maybe ICSI or further on, but it has not been shown that it doesn't help you in deciding, and it is not consistently affect the pregnancy rate in IUI cycles. Advanced maternal-paternal age is always a deterrent. It negatively impacts pregnancy rate. Similarly, paternal obesity and maternal BMI. We know that letrozole and clomiphene have similar results, and the best outcome women for IUI are ovulatory dysfunction and unexplained infertility. This is very much understood, apart from the donor IUI cycles, which we are not going to discuss either ways. And most pregnancies occur in the first 4 cycles, so that would be a good way to go. Now, let me just discuss quickly a couple of cases that I have put together for you today. The first one, and who all need IUI, we'll just discuss how they differ in their ovulation induction techniques. Now, first patient is a difficult anovulatory PCOS woman. She is 25, primary infertility of 3 years. She hardly has menses once in 2 or 3 months, very much oligomenoric. Her BMI is 30. She is moderate. She has features of hyperandrogenism. Ultrasound findings are okay, uterus and all is fine, but the ovarian volume is large, 21, 22 cc, and antral follicle count is 20 to 25. HSG is normal, seminal fluid analysis is normal. Now, in this patient, basic investigations other than TVS, tubal factor, and seminal fluid, all those are okay. There are some extra tests we will certainly do. You will all agree with me, because she is a difficult PCO. We will be doing probably an AMH. I hope you will all agree. And in case her AMH was 15.6 nanograms, which is very high. And we will definitely do a thyroid, prolactin, and some tests for metabolic dysfunction in all women who are diagnosed with PCOS. Now, how did I did ovulation induction? I'm sure for you all it will be letrozole, but clomiphene citrate plus metformin is also equally good. And I will start this kind of a patient probably mostly on letrozole and metformin. So I started this patient with 5 milligrams of letrozole, the standard day 3 to day 7, along with metformin, 850 milligrams twice daily, some lifestyle advice. But she did not ovulate in the first cycle. So with this kind of a scenario, what are the next things that we can consider for ovulation induction? So there are many protocols now that have been accepted for women who do not respond to the standard dose. PCOS women who do not respond to the standard dose of letrozole or clomiphene. When you, after adding the adjuvants also, you can increase the dose to 7.5 milligrams. You can give an extended letrozole for, instead of 5 days, give it for 10 days. Step protocol, in which it means that you start with a 2.5 on day 2 or day 3, 2.5, then 5, 7.5, 10. So 4 days you give in a increasing manner. Single high dose of 20 milligrams on day 3 has been given. Letrozole plus metformin, you can also add metformin and inositol combinations if only metformin you feel you need more. And of course, there have been reports of adding clomiphene plus letrozole. So this particular, and here I want to discuss whether there is a role for ovarian drilling in this kind of a patient. Now that is again extremely controversial, but then that is why, since she has not responded to letrozole and after adding metformin, many people would argue that ovarian drilling is a choice for her. But again, the point is that we have to be very selective for which patient we do a laparoscopic ovarian drilling. And based on all the recent papers that we have gone through and those who have been published, we know that women who are unlikely to benefit from ovarian drilling and those who are obviously, we will consider only those who are resistant to clomiphene and letrozole. So women who are obese, they are unlikely to respond well. Those who have a higher duration of infertility, like more than 3 or 4 years, those who have low basal LH levels, those who are markedly hyperandrogenic, very high, whether you're doing a free testosterone or a total testosterone or a free androgen index, if they are very high, and clinically also if she shows she is very hyperandrogenic, and those who have a high basal AMH levels. So these people are not suitable for ovarian drilling. This has also been endorsed by the new, international PCOS guidelines, as we are all following those nowadays. So the best patients who are likely to respond to ovarian drilling are those who are thin, who have a low BMI, and those who have a shorter duration of infertility, maybe less than 3 years or 2 years or 3 years, and those who have a high LH levels. So we have to keep that in mind. So this particular patient, my favorite thing to do if they don't respond to 5 milligrams is I go to 7.5 milligrams a day. And this patient responded to 7.5 and got pregnant in the second cycle of letrozole 7.5 milligrams per day. So that was patient number 1. And of course, it was followed with IUI, only letrozole IUI, letrozole metformin IUI. There was no gonadotropin given for this patient of PCOS who was undergoing IUI with me. Now, next comes a case of unexplained infertility. Have a look at this patient's profile. She is 26, married for 2 years. She's a teacher, anxious to get pregnant. She has regular periods, mild dysmenorrhea, no sexual complaints for either partner, regular cohabitation, no medical chronic illnesses in either partner, no prior surgeries, no significant family history. Mother is probably hypertensive, no addictions, occasional alcohol. BMI is 26.4. Husband is average height and built. Routine tests are all within normal levels. So she's a classical case of, I would say, unexplained infertility, because these are by definition, these are the minimum tests that you need to do for to define her as a woman who's probably unexplained, because you don't find any obvious reasons other than the routine blood tests. You do a transvaginal scan, you do a HSG for tubal patency and a seminal fluid analysis, and that was all within normal limits based on WHO 2020 parameters. Some WBC was high for this patient, so some course of antibiotics was given. Now, for this kind of a patient, obviously, we are considering her whether she's a candidate for IUI. Or we want to do expectant management more. I don't think anybody will do that. We can do some further investigations. That is what I want to discuss, and then on to discuss what we did for her treatment for IUI. Now, expectant management, let's drop that. So for what are the further tests that we can consider for this kind of a patient? Ovarian reserve test, I think most of us will do, at least an AMH. Will you test for genital COX? Again, I think there will be a divided opinion amongst even our own peers from our own country, because there are many practitioners in the north, otherwise also, who feel that a test for genital COX is a must. For people like me, I don't somehow see so many, and I would look for genital COX if she has a history, or if she has some, HSG related or ultrasound related, any features of a chronic sequelae of genital tuberculosis I might look, but I would never ever do a test like PCR or something like that. TB PCR or something like that. So that is number one. DNA fragmentation test, there was something that there was a lot of discussion in between. I'll just come to that. Will you offer do you want to do a diagnosis because her HSG is normal? Should we consider many consultants who feel that we should be doing a diagnostic laparoscopy or diagnostic hysteroscopy before proceeding for an IUI? Now, again, that will be a very, very controversial point because not everybody is going to agree. If the tube's looking normal and if the good transvaginal sonography is not showing you any features of possible pelvic adhesions, there is no point at all in doing a diagnostic hysterolaparoscopy, which is a pretty invasive test. The logic for going for diagnostic laparoscopy is people say that it is because you will not see minimal mild endometriosis, or you will miss extremely minimal intrauterine adhesions or something of that nature. But like I showed in this TVS clip, this TVS clip showed very clearly that there is a very good normal size. Everything is normal. There is a good sliding, organ sliding. You can see both the ovaries are perfectly placed. There is no point in doing a diagnostic laparoscopy in this kind of a patient at all, either for a hysteroscopy. But the only one issue which you cannot test by any other means other than laparoscopy is tubo-ovarian relationship. That is the only thing, which of course we don't think unless you have very, very rare situations like this, where isolated adhesion affects the tube and the infundibulopelvic ligament, and it's a very long tube and a very long ovarian ligament, and both the tubes are facing upwards. There is no tube-ovarian relationship, absolutely. The ovary is in the pelvis. The tubes are facing towards the upper abdomen. So basically the point here was that this is probably the only point which is tubo-ovarian relationship, whether that is okay or not. And if you feel you need to do that, that is the only reason why you might consider a diagnostic laparoscopy in a case of unexplained infertility. Now, there was also a lot of talk about DNA fragmentation, whether it should be part of infertility workup. Now, I am not quoting none of the guidelines are saying, so don't take me wrong. I am not saying that you should be doing a DNA fragmentation, but there are quite a few people, a group of researchers who feel that there is a logic in doing because are we talking about idiopathic infertility? That there is a role of looking for high sperm DNA damage, and this was a publication which tried to prove that, and there are many others also. But then there was also a lot of talk in between whether in unexplained infertility DNA fragmentation test will be able to help you decide whether a IUI is indicated, or whether it will help you tell about the outcome of IUI. But no, all the meta-analyses have shown that DNA fragmentation is probably not going to help you in deciding on the IUI pregnancy outcome. So if the sperm DNA fragmentation is high and a patient is normally for IUI, you would have thought of an IUI, that does not indicate that you should move over to ICSI because the DNA fragmentation is high. So, but then this is different. I don't need to, it's not pertaining to this talk, but then the only people who you might find suitable for DNA fragmentation testing, certainly recurrent pregnancy loss and patients undergoing ART, you might consider them. So, for unexplained infertility, these are a couple of points that I would like to add. There are lots of publications that say that IUI is certainly a best choice. So, there are also a lot of papers out there which tell us that in case of unexplained infertility, whether IUI should be the first line option or one should go over to IVF. Because you and me both know that 3 or 4 cycles of IUI success rate per cycle will not exceed 6 to 10%. IVF success rate will be much higher. Is that a reason enough for us to decide that she, in unexplained infertility of 3 or 4 years duration or more, is not a candidate for IUI? But I believe that all evidence points otherwise. And IUI is certainly indicated for all cases of unexplained infertility as a first-line treatment option. So for my patient, what I have done for her is simple ovulation induction with letrozole 5 milligram and timed intercourse for 3 cycles. Because her married life was, I think, only 2 years or something, simple intercourse. She was not pregnant with that. Then I started her on a combination of letrozole and HMG, highly purified HMG. Typically, I give like this, which means day 3 to day 7 letrozole, and then add a HMG HP from day 6, day 7, day 8, 3 days. And if they have day 8, we start the scan. If they have good number of follicles, and then we will, if she is developing follicles, then that's it, only 3 days of gonadotropin. If we feel, give me a minute. If we feel that she needs a longer duration of gonadotropin, then we can give it for further more days till the leading follicle becomes at least 15 or 17 mm. We can decide on case-to-case basis. This patient was, of course, not pregnant after 3 cycles of timed intercourse and 4 cycles of a gonadotropin combination IUI. She was not pregnant. Every time she was ovulating, and every time her post-wash semen sample was 20 to 25 million post-wash, 100% more time. So that was case number 2 for unexplained infertility. We will be doing an IUI and we will be doing the gonadotropin and letrozole. Most of us will do a combination. I don't think there is a place for gonadotropin only IUI in an unexplained infertility. Now, third is a case of endometrioma. Quickly, I'll go through it. She's 26, married for 1.5 years, anxious to get pregnant. She has no symptoms. All routine blood tests are normal. Her HSG bilateral tubes are patent. The seminal fluid analysis is normal. She has a small 3 centimeter endometrium. Now, again, most of us will not agree on a surgical option for her. I think I have missed the AMH. AMH was, I think, 2.8 or 3.1 or something like that. AMH was good. And either way, she's very young. And on the scan, the transvaginal scan that we did, both the ovaries are deviated to one side, towards the right side. And both the ovaries are stuck to each other and to the there is no pelvic sliding signs are negative. So I did take her up for surgery, and adhesiolysis was done, and with to release both the adnexa and to create a normal tubo-ovarian anatomy, and the endometrioma was neatly excised. Cystectomy was done. So in this kind of a patient, of course, the questions come, there will be many questions will be raised, whether you should operate, you should not operate, and there may not be many straight answers, and we may not all agree with each other, but largely there is certainly a role of surgery, and those who we can plan surgery if needed, they are women who are young with a good ovarian reserve. And of course, other indications, like if they have pain and they have a severe disease, large endometriomas. This one had a 3 centimeter endometrioma, but she was young, and her ultrasound report clearly showed that her tubo-ovarian relationship and pelvic anatomy is not conducive to doing an IUI. Therefore, I did plan the surgery. After surgery, then mostly again the question will come whether a combination of gonadotropin and letrozole or a gonadotropin IUI only. Here again, I would like to reiterate that clomiphene citrate or letrozole both will be equally good. We want more number of follicles here, at least 2 or 3, because superovulation will help. I mean, we don't want hyperstimulation, but we certainly want a good number of eggs. And so I don't think there's a role for only oral gonadotropin, oral ovulogen with IUI. I would certainly go for letrozole or CC and gonadotrophin combination. Again, I will usually give it first 5 days the oral ovulogen, and then day 6 start the gonadotrophin, and then continue till you have good number of good size of follicle. Gonadotrophin only IUI may be considered in this kind of case, but it is usually not indicated. This patient, as expected, got pregnant on the 3rd cycle of IUI. And she is already delivered. So grade 1, grade 2, clean a pelvis. They normally get pregnant if they are endometriosis patients. Now, I think this is my last case. Again, a 25-year-old woman, married for a couple of years, anxious to conceive. She has a history of very irregular cycles, mostly withdrawals, with estrogen and progesterone both. She has a history of late menarche of 15 to 16th year. She's never been investigated or diagnosed properly. So she has met me in this situation. She is average height and weight. All secondary sexual characters are normal. Normal puberty and thelarchy you can see. But then she doesn't get progesterone withdrawal only. So you know that there is a problem with her. Investigations, abdomen pelvic scans, and day 2 you have to do FSH, LH, AMH, and the other hormones like thyroid, prolactin, and E2, seminal fluid, and the tubal factor test have to be done. So small uterus, ovarian volume also small, 1 or 2 very small follicles are seen in both the ovaries. And FSH and LH are both very low. The AMH is 2.49. So having seen this, you know that this is probably a case of hypothalamic hypopituitary hypogonadism. And now this is again a case where you need ovulation induction for her to get some follicles. Now, again, the question will come whether we should take her directly for IUI or IVF. I would certainly take her for IUI, push for IUI, because she's not only young, she's not undergone any treatment. Her pelvis is fine, her tubes are fine. So yes, I did put her on for an IUI cycle. Questions which might come is what gonadotrophin, what starting dose. We have to remember that we have to generally give them a higher dose of gonadotrophin. The gonadotrophin range may be to the range of IVF cycles. I mean, you have to start with at least 150 based on her BMI and age and all that, 150, 200 if necessary. Sometimes you have to go more. Which gonadotrophin, HMG or recombinant FSH, both are fine. So this patient, I did IUI, I think 2 cycles, 3 cycles of failed IUI, but every time she ovulated with the gonadotrophin stimulation. Again, here we will give only gonadotrophin. There is not much role of giving clomiphene or letrozole, although one can, I guess, letrozole. But this patient, they are ideal candidates for starting them on with only gonadotrophins. Patient eventually got pregnant with her first cycle of IVF after 3 cycles of failed IUI. So thank you very much. I hope the cases that I showed, they were all practical, how they were practically managed, and I hope I covered some forms of ovulation induction for IUI. Thank you so much.
Thank you very much, ma'am. Comments from chairpersons? Otherwise, I'll be asking Madam some. I'll be basically, ma'am, we are so grateful to you because through those clinical cases, you have actually walked us through PCO, through unexplained infertility, through a patient with a male factor infertility, and basically also told us the utility of investigations like histrolab, when to do it and when not to do it. Though all said and done, we like to assess tubal patency, but a good TVS gives you so much information about a normal ovulating woman with everything normal on TVS must be having normal tubes also. So there is some, I think, presumptive diagnosis you make in your mind before you proceed. That is how I think
HSG also is done. So HSG was normal.
Yes, ma'am. So, ma'am, what is your opinion? Do you do sonosalpingography or
No, actually, I have somehow not been able to pick that up. I am not very happy with it.
yes, same here.
Uh,
Yeah, I also
yeah,
I tried it multiple times, ma'am. In fact, I get some
yes.
referrals, saying that please do SSG for this patient, but it is so
I'm somehow
very
not
confused.
convinced. It doesn't work for me. I did try. It works for some people, but for me, it
Doppler, when
doesn't
you,
work. My major thing is that it's not reproducible also. So, yeah,
I think you should use a Doppler when
yes.
you're doing it. So then you can see the flow of the thing and you can record it when you
Yeah,
do the ultrasound. So you can document it, but
yeah.
Doppler helps a lot when you cannot really make out whether the fluid is going or not, because you'll only know
Hmm.
otherwise that the fluid is there in the pouch or not. We do not know from which side it has come. Though you can also, the one advantage of SSG is that you can see the fimbria, you can see the fimbrial movements, and you know that they're not agglutinated.
I think another biggest advantage of SSG is that you have a
No exposure to radiation.
one-stop clinic. Otherwise, you have to call the patient for at least 2 times or 3 times. I think that is the biggest advantage of a SSG, that at one go you can finish a basic investigation.
No, but the other thing is that there's no exposure to radiation, no? Because radiation again is a issue when we are doing an HSG. HSG, that's why.
Yeah,
And ma'am,
guess
we
that
just
is
had
very low.
we had a speaker in one of our programs very recently. She said she combines a hysteroscopy with an immediate TVS. So they do a hysteroscopy, they see the influx of fluid into the cavity, those typical bubbles going into the open gaping ostia, the open ostia, which give you that typical good appearance.
So that
And
is
then
a standard test which we also do, which is called the bubble test. That also gives a reasonably good. So you put air bubbles. This is a standard technique
yeah.
for seeing tubal patency through hysteroscopy. No ultrasound, by hysteroscopy. So there's a bubble test that you do.
Yeah, and
Fine
then she
bubbles are created by
yes.
mixing gel and some normal saline, and then you push it as you close to the vein, push it, and you can very well document that all the bubbles have gone through. So if done properly, it gives you a fairly good idea about tubal patency.
Thank you so much, Sujata. Comprehensive talk and the clinical scenarios which you presented. I'm very grateful for the lecture, ma'am, and always looking for your, guidance and such academic feast in the future also. And thank you so much, ma'am, from Team
Thank,
Fortisphere.
thank.
So now I request Dr. Purva and Shweta together introduce Badri ma'am and then introduce the panelists very, very briefly so that we can start the panel.
I think we should just go straight for it because we've already almost half an hour late. So I don't
Yes.
think an introduction is required. She can just
Would you
tell the names
Yes.
of the
Yeah.
panelists because I should know the names. That's the
So
only
just
thing.
flash the
Yeah.
slides one by one.
Yeah.
So panelists,
Yeah,
madam, see the face
yeah,
and you
sure. Yeah.
see
There's no
the
need to introduce anybody. You can just, yeah.
So moving to our panel discussion, that is on hot seat tackling the toughest ovarian stimulation scenario by another than Dr. Madhuri Patil ma'am. Madam is Vice President ISAR.
Oh, yeah, forget. Don't
With
introduce.
her,
Everybody knows
we
me.
have dynamic panelists, Dr. Aditi Trivedi, Dr. Arnav Pai, Dr. Aswathi Shanavas, Dr. Dharam Shah, Dr. Dimple Chatwani, Dr. Divya Kumar, Dr. Harshal Shah, Dr. Meenal Chitgupkar, Dr. Niharika Tyagi, Dr. Ruchi Chetri, Dr. Tejas Gundewar, Dr. Varun Gaitunde. Ma'am, the mic is yours. We look forward for a wonderful panel discussion.
I don't know. I've just prepared my slides, so I hope they are interesting. I'm not sure.
Thank you for accepting the invitation, Madam Madhuri ma'am. I pestered you repeatedly till you said yes. Thank you so
Oh,
much.
because I just finished my other panel, yeah, and yesterday also I had to moderate the whole session, and I had a talk which was given last minute to me, so it was too much for me. So we know that challenges with ovulation induction for ART are there, and we have to see that our protocols are basically efficacious and safe. And what we need to do is we have to prevent the follicular phase progesterone rise, that is basically the late follicular phase. The cycle has to result in a pregnancy. We have to prevent poor response and also ovarian hyperstimulation syndrome. We should have a lower risk of multiple pregnancies, decrease imprinting disorders as well as epigenetic abnormalities, and also at the same time have a better neonatal outcome. So choosing the correct dose of gonadotrophins as well as choosing the right analog is important to avoid either a poor or an excessive response, because we know that with excessive response we have increasing number of immature oocytes, and also there is a great risk of ovarian hyperstimulation syndrome. And we say that the response is more if there are more than 15 oocytes that have been retrieved. And with poor response, where we retrieve less than 4 oocytes, it indicates diminished ovarian reserve, lower pregnancy rates, as well as need for a higher FSH dose. So therefore, most individualized protocols are based on several parameters of ovarian reserve test, and the most important of them is the age, the AMH, and the antral follicular count, and this is further amended for the BMI. So we know that at the same age, BMI and hormonal profile, we can have different ovarian reserves in different people. They require different types of COS protocols, and also the strategies like the analogs and the FSH starting dose are totally different. So let us then go with the first case. And she was a 30-year-old patient who was married for about 4 years. She had irregular cycles and they used to come every 2 to 3 months. And she was trying to conceive for the last 3 years. The HSG was normal. A hysterolaparoscopy was done where the uterus was normal. The tubes were slightly dilated, congested, and inflamed, and they were unhealthy looking. The right tube was adherent to the ovary. The left ovary was normal. The pouch of Douglas had adhesions. Adhesiolysis was done, and the bilateral tubes were patent on chromoperturbation. And at that same time, bilateral ovarian drilling was done. So this was before she came to us, and the semen analysis had shown acinoteratozoospermia wherever she took treatment earlier. So what is the evidence for laparoscopic ovarian drilling in women with PCOS, and does it improve the outcome? Anybody can take it because I really can't see everybody.
So, hi, this is Dr. Dharam. So, I think the rationale for laparoscopic ovarian drilling is there in modern IVF practice, but it should be reserved for possibly remote places where there aren't too many facilities. But for most modern cities, we already know that these ovaries are very, very delicate, and doing a stimulation and trying to get as many oocytes at the outset with stimulation using rec FSH from the start may be beneficial. And even if laparoscopic ovarian drilling has to be done, it should be done with a very minimal current and just take a few calculated incisions on both the ovaries.
Yeah, so if you look at the comparison between laparoscopic ovarian drilling and gonadotrophin, we know that both these things are second line of treatment in patients who have anovulatory cycles. And if you look at the disadvantage of laparoscopic ovarian drilling is in decrease in the ovarian reserve if you overdo it, and also increased risk of adhesions, and gonadotrophins are better. I don't think you should get more follicles, because as you want, when you stimulate, if you get more follicles, the quality of the eggs is not good. You're also not looking at the number of good quality embryos we are getting, as well as the risk of hyperstimulation that the patient is going to have. And the other thing is also at the epigenetic changes, because with that many follicles, there's always abnormalities in the mitochondria of the oocyte. So you have to stimulate these patients, individualizing the protocol, where you need to start with with low dose, and what we should aim it as about 15 and at the most 20 follicles, but I don't think we should aim at 20 more than 20 follicles. And I think younger generation wants to aim, but that's a wrong treatment what is being given. So before she came to us, basically, she had taken 2 cycles of letrozole with timed intercourse, though follicular monitoring details were not available and she didn't have a pregnancy. Then she underwent almost 5 cycles of letrozole with HMG and IUI, and there was no pregnancy. And therefore, at that point of time, she came to us. So when she came to us clinically, there was no positive finding. Her BMI also was normal. Uterus was normal, and both the ovaries were enlarged with increased volumes, and the antral follicular count in the right ovary was 34 and that in the left was 24. If you look at a hormonal profile, you can see that the FSH-LH ratio was not altered. All the other parameters were totally normal, but her AMH was 7.5. Her SHBG also was normal, so I don't think there was much of a problem. So what care would you take when you are stimulating a patient of severe PCOS who is resistant to clomiphene citrate?
So, ma'am, are we talking about IVF stimulation or
Yeah,
we
now
talking
the patient is resistant to stimulation. There is resistance as well as even if she is responded, there is failure of conception as we saw in the previous cycle. So I'm talking about this patient. So she is now going to be taken for ART. So what care would you take when you're stimulating this patient? And she's got severe PCOS because we've seen that the antral follicular count is 34 and 24. We've seen the AMH is 7.5.
Correct. So I think from my side, pre-stimulation metformin, I would like to add 500 milligram twice a day. And
her everything was normal. I mean, her glucose tolerance and everything was normal. So
yes, but
she
ma'am,
didn't
I
have
think
any insulin resistance.
I know, but I guess I would say that there would be hardly any patients where glucose tolerance would be abnormal, and then you're
Why?
adding.
There are so many patients who have it abnormal.
So
I think more
I
than
think
50% of the
so.
patients have an abnormal glucose tolerance.
So I would put it this way: metformin probably to improve the to reduce the risk of OHSS. I think let me
It
put
just reduces. Are you going to use a long agonist protocol?
no. I'm
No.
going to
If
use
you're not going to use
antagonist
a long
protocol.
agonist protocol, it does not reduce the risk of OHSS in an antagonist protocol. The Cochrane review, which was published in 2016, and it says that it does not reduce the chance of OHSS in an antagonist cycle. It reduces only in a GnRH agonist long protocol cycle.
Okay, taken. Okay, ma'am. Then the only thing I would do is a flexible antagonist protocol. Recommend FSH 23.7 is the BMI. I would like to start with 187.5.
How did you calculate 187.5?
So 225. No, BMI is normal, ma'am. So either it is 225 or
Why
187.
can't you start 125 or why can't you start 150? Why 87.5?
150.
No, I would like to not 150 would be a lesser dose according to me.
Why?
No.
But her BMI
No,
is
150 seems to be fine. So we will start from a softer protocol because anyway we want to prevent OHSS. So
So
150 will be
I'll
good
finish.
dose for
I'll
her.
finish. So according to me, if we start with a lower dose, and then if you want to scale up the dose later on, there are chances that it will take a longer stimulation. So I would prefer to start with a slightly higher dose. Let there be selection of the follicles, and then if you see that there is too many follicles are being selected, then you can take down the dose. So I would like to go that way.
anybody else with
The
any
three
opinion?
most important points for stimulation in PCO, in my opinion, of course, is first we have to always choose the antagonist protocol. We have to always use the agonist trigger because we
I
never
don't think
want
so
to
because if you're stimulated wisely, many a times
No.
you don't have more than 10 to 12 follicles. Your E2 levels are less than
It
2000
can
or
be.
2200. So you can still go in
Okay,
for
so
revenge
anybody more
transfer.
than 15 oocytes, I would always give the agonist trigger. And for such candidates, I would always like to do the freeze-all protocol and avoid doing fresh transfers because in
I think
PCO,
Dharam, we are
get
talking about
the
stimulation. We are talking about stimulation and not the freezing and everything.
Stimulation, I will like to start with a low
but my
dose protocol.
objective of
Like
stimulation
150
is to
for her
not
will be
plan a fresh
fine
and to consider freeze-all.
because of her antral follicle count. It's much high. And maybe I can give a suppression with OCP in the prior cycle before starting a softer
The
So again,
protocol for
OCP
first
stimulation.
pre-treatment,
principle
I
to
would never
remember
give
that
OCP.
OC is contraindicated in an antagonist cycle. it is contraindicated. So if you want to give, what you need to give is you can give either estrogen or you can give progesterone for about 8 to 10 days in the luteal phase. Because it has been shown that the pregnancy rates and the live birth rates are lower when you are using oral contraceptive.
Because it'll cause oversuppression
No,
and the
I
LH
think
surge won't happen with the agonist trigger if you give prolonged OC pills.
No, ma'am, I would like to differ, Madhuri ma'am, I would like to differ on this. I don't think so. OC pills are contraindicated in an antagonist protocol. The evidence that we have regarding OC pills and live birth rates is when you're talking about fresh transfers and not in terms of frozen transfers. So I would not.
And we can use
So
myotrol
I would not say
chiropractic
that oral
combinations
contraceptive
also as
pills
an
are
adjuvant.
contraindicated when it comes to an antagonist protocol.
No, the main problem is when you're giving an OC pill in PCOS, you may have to use an agonist trigger. So if there's an endogenous LH is very, very low on OC
The
pill,
agonist trigger
sometimes you
won't
may
work.
end up getting
They will not
epipolysis.
work.
Yeah.
And
Yeah,
therefore,
they
you should
don't
not
work.
use OCPs.
And one
And
more
even if we
point,
give
ma'am.
OC pills, it should never be more than 10 days.
We
Correct.
can use
And
adjuvants also for her, like chiroinositol, myoinositol combination, because her BMI is absolutely normal.
It's normal. So then why you want to use any adjuvants? Why you want to increase the cost to the patient? You know how much inositol
But
cost?
she has already, she didn't respond previously. So
No,
it's like
she's
optimization of
responded
cycle.
to letrozole with gonadotropins.
The cost of chiroinositol, myoinositol is not much than the cost of IVF cycle. So I will like to optimize the outcome of the IVF cycle. I will not like to leave anything. Whatever we have, we should offer her.
What you're eating normally has inositols. Why should you supplement it?
But the ratio has to be optimum.
How do you know that the ratio is not optimal?
And ma'am, do we have evidence?
Because she is not responding, madam.
And there is no evidence for using inositols because
To
all
improve the
studies
stimulation.
have been done in Italy because inositol is produced over there. All of them are cohort studies and all of them have very low sample size and therefore there is no evidence. There are no RCTs also which are there. And in my experience, initially, almost about 10 years back when it came, I had done a study wherein we use vitamin D and we use combination of inositols with vitamin D. In patients of PCOS, we did not give anything for ovulation to see whether the patient ovulated or not. And we also look at the androgen levels. And what we found is that there was no difference in the androgen levels and the patients also did not ovulate. So nothing gets optimized when you are using inositols.
ma'am, in CC resistance, I think two ways to go about it. First of all, is counseling patient because when you start with a low dose, you may require longer days of stimulation.
Yes.
Or you can combine letrozole and gonadotropin so that you minimize the over hyperstimulation. But in day and age of agonist trigger and freeze-all, we are not much worried about OHSS at this point. But starting dose of 150 should be fine. And in case if you feel that there's overstimulation, use an agonist trigger and freeze-all.
One more, Madhuri ma'am, one more point. I think in the scan finding it is written that the stroma is more. If the stroma is more, then there are chances that she would not respond to your gonadotropin.
Yeah, so you have to increase, na? So therefore
But
you have a low dose
you might as well
protocol.
start with a slightly higher dose and then
You
take
have
it.
a low dose protocol.
It's better to
I'm not
start
even
with a
saying
lower dose
chronic
and
low
then
dose
to
protocol, but you can use
escalate
a
up.
low dose protocol wherein if she does not, because the chronic low dose you have to change
We can
only
increase the
after
dose.
14 days, whereas in a low dose we can change after a week. So I think that is much better in this patients. And basically, if the patient is still going to go for a non-ART cycle and she has resistance to letrozole as well as to CC, then probably you can add metformin and see if the patient is going to respond. But metformin should not be added to letrozole because there are studies which have shown that adding metformin to letrozole has not helped in ovulation, but adding metformin to clomiphene has definitely helped. And this was being shown in the OWL study, which was published by Dr. Legro. But that's a very old study also. I think it was published in 2008. So we know that many a times that the response is not predictable in patients with PCOS. So how would you predict the response to stimulation with both either CC and gonadotropins?
How do you predict?
Yeah.
I think physically, I would go with BMI as one of the predictors that what could be the dose that is required. Second, scan findings, where a higher stroma would indicate a poorer response to stimulation. Third,
You do a Doppler?
Sorry?
Would you do a Doppler?
I do a Doppler routinely, but in my pilot study, I found that it's not been useful. Neither the RI, neither the peak systolic velocity of the stromal Doppler has changed the results. I've had patients where peak systolic velocity has been more than 10 and they have not responded, and I've had patients where the peak systolic velocity has been less than 5 and still they have responded. So it's been a mixed result when we've done the study. Third thing, based on the AMH levels, higher the AMH, poorer may be the response. But again, I would not say that that's always the case. As I said, that AMH can be higher and still the patient can respond. So only these are the things I think I would decide. According to me, the most important
Even
is
even
BMI.
LH is a good marker. If LH is more, much higher, then the response is also not good.
I
Ma'am,
don't
on
do LH.
Doppler,
I don't do LH because I think
No,
that
the baseline FSH LH.
No,
So
no.
if LH is on the
Actually,
higher side,
nowadays they don't look at the LH. Why? Because it's a
variant beta LH
chronic
is
LH
always
level,
there.
and it really
Variant
does
beta
not
LH is
affect your
there.
stimulation. Therefore, today your LH levels are not looked at.
ma'am, but on day two, if you do a Doppler and if the stromal flow is showing very high, these are the patients who require low dose of gonadotropins, and these are the patients who are at higher risk of OHSS. So we have to be careful with the gonadotropin doses. So Doppler definitely does help us when we're starting deciding the starting dose.
Yeah, there are a lot of controversies. Both there are studies for and against it, but there's no conclusion which is still has been reached. But I think higher AMH levels, usually the patient is resistant, and that is because we know that AMH inhibits the recruitment of the pre-antral into antral follicles, and therefore, if you have a high AMH levels, the follicles do not really get recruited. It also inhibits the action of FSH, and a high level also inhibits the aromatase activity, and therefore the response in these patients who have a high AMH is usually there. But in these patients, once they are resistant and they are not growing and you increase the dose, basically at times you see that suddenly there's flare of the growth, and that's so therefore we can say that when you're stimulating these patients with high AMH level, it's just like walking on a rope, and you just tilt your balance and you can just go into hyper response. So we've already spoken about all the multiple markers which we use, and if you compare FSH and AMH, which do you think is the best single marker?
of course, AMH.
AMH.
Why?
Ma'am, can you ask the question again?
AMH has been introduced recently as
AMH
one of the
or
diagnostic markers
antifollicular
of.
is
It is
the
not
best
related
single
to.
marker to predict response.
Antral follicle count.
Why?
I think
Ma'am, there
because
can be lab variations, but the AMH
cycle
as
to
to how
cycle
well it is
variations are
done, we
there,
don't
and
know.
I would go with antral follicle count as a better marker than AMH.
Ma'am, what you see, you believe, because AMH, there can be a lot of lab variations. We have itself are seeing that some labs, there will be very varying
No, but if you,
limits.
I mean, where there's no lab variation, AMH is always the best marker because it also encompasses the smaller follicles which are not seen as antral follicular count. And therefore, it is a much better marker because it encompasses more number of follicles than what you have when you're doing a antral follicular count. So, so do you think we should use only recombinant FSH, or one could also use urinary gonadotropins and HMG? Whether that is contraindicated in women with PCOS?
No, ma'am. There's enough study which
It's
shows that the choice of
not.
gonadotropin doesn't matter. In fact, even with the most
Doesn't matter,
recent
yeah.
Megaset HR trial, we saw that Menopure using HCG-driven LH activity, the pregnancy rates were exactly the same. In fact, the early pregnancy losses were lower when we use HMG with added HCG.
Is there any difference in the pregnancy rates when LOD is compared with low dose of FSH in a non-ART cycle?
I don't think so. LOD or low FSH. It all depends upon having the egg growth. If egg growth is there, I don't think so there's any difference when it comes to pregnancy rates. As long as remaining things are fine, and with low dose FSH or with LOD, you are able to grow a follicle. I think that's okay. Good semen parameters,
When you are
normal tubes.
after you do a laparoscopic ovarian drilling, you require a ovulation induction drug.
You may require, not necessary that every patient is going to respond to your laparoscopic ovarian drilling.
So therefore, they still say that I've not put the forest graphs here because I didn't want to make it so complicated. So therefore they say that low dose FSH is a better option, though it is much expensive because the cost is for every cycle as compared to laparoscopic ovarian drilling, which is once you do it, its effect, whatever is seen, lasts for a longer time. So this is what we did for this patient. So because she had undergone so many cycles of IVF, so we posted her for ICSI. And what we used was an antagonist protocol, and we gave recombinant FSH for 4 days. And then on day 4, her E2 was only 74. She had bilateral multiple small follicles. There was no dominant follicle. That is, there was no follicle which was 10 millimeters or more. And so we added 75 of LH activity by giving HMG. On day 7, still there were no dominant follicles, but we continued the same dose. And when she came on day 9, she had a lot of asynchronous growth of follicles. And there were only 3 follicles which were about 15 to 16, and all the other follicles varied from 8 millimeters to 13 millimeters. And so at this point, we increased the dose of HMG to 225, and we continued the antagonist. And on the next day, the E2 was 2317 and the progesterone was less than 1. We gave an agonist trigger. At that point of time, we had 4 follicles, which were 17 to 18 millimeters. There were 7 intermediate size follicles, that is between 14 to 15 millimeters. And there were 5 follicles, which were between 12 to 14 millimeters. So because we had a lot of small and intermediate size follicles, we started cabergoline on the day of trigger for this patient. So basically we did ICSI because she had asthenospermia. So the total dose what we gave was 150 IU for 9 days. We gave 75 IU of HMG for 3 days and 150 IU for 2 days and 225 for 1 day. The total number of oocytes that we recovered was 16. 15 were M2, 1 was GV. Total number that fertilized were 14. No embryo transfer was done, and 13 embryos were frozen on day 2. She had only mild OHSs, which did not require any treatment. And a frozen embryo transfer was done in an HRT cycle because we did try ovulation induction cycle with letrozole, but she did not ovulate, and therefore we went for an HRT cycle because I prefer doing a natural cycle or an ovulation induction cycle for my FETs. 6 embryos were thawed and kept for blastocyst culture. 5 of them survived. We transferred 2. Both were grade 2 blastocysts. And then we froze 2 blastocysts, grade 3 AB, because on day 5, these were early blastocysts, and these blastocysts which we froze were on day 6. Luteal phase support was given with progesterone, and then she had a positive pregnancy and a full-term delivery. So I would like to ask all of y'all, when you'll see a patient of or any patient who comes to you for ART, do you look at her previous reports and whether that helps you guide the selection of the protocol?
Yes, absolutely.
Yes, ma'am.
Very
Absolutely.
good
We look
point.
for the response, the number of the like gonadotropin dose, the response, the size of follicles, number of follicles.
So what basically
all these we definitely check.
would look when you're looking at a gonadotropin cycle?
And so her starting dose of stimulation is very important. Which was the protocol? Was it the agonist or the antagonist protocol? When was the antagonist started? When was the triggering done? Was there the use of a HCG trigger?
One point, which is the most important.
Starting dose,
Starting dose.
definitely, and the response, the selection, and the number, like for how many days she was given the stimulation.
Number of oocytes and the embryos formed.
So FOI and FORT is what you're looking for. Is the number of follicles and the number of M2s gotten corresponding.
You have to select the right drug and the dose. You have to look at what level.
What the outcome was.
Yeah.
At what level she started responding. Suppose you started with 150 and she's responded, so 150 is okay for her. But she doesn't respond to 150, but she requires a 225, then it's best to start her way at 225.
225 only.
So that threshold has to be identified from the previous cycle, which will help you in selecting the dose. So how do you prevent all of your...
Madhuri, for me, I have one question for you. In the stimulation, when you gave REC FSH and then she did not show a response, you added an HMG. Why didn't you reduce the dose of REC FSH? She was anyways not responding to it. And why didn't you keep continuing with the HMG? Means you increased it to one.
I normally like to use drugs from two different companies because I'm not very sure of how much the cold chain is maintained. And therefore, even if I add another drug, I would always continue the same drug. So that is the reason why I don't reduce. And wherever I'm using a combination, I usually use it in that proportion. Only in my poor responders, basically, I think I would use only HMG. But in my PCOS patients, my first choice would be a recombinant FSH. And only if they do not respond to recombinant,
then you supplement with HMG
in the woman with PCOS. We have also discussed the role of metformin. And I would like to ask, is the oocyte quality and embryogenesis affected in women with PCOS?
Yes, ma'am, absolutely. Because of the higher risk of early pregnancy losses, there seems to be a mitochondrial deficiency in most women with these eggs. So that was the one interesting thing that we found in the Megaset HR trial, that other than just euploidy status, maybe HCG and LH may affect oocyte quality to prevent early pregnancy losses.
No. So
when they are hyperstimulated.
No, I don't want you to talk with all these Megaset trials, which are company-based trials, but it is basically, I want you to look at the mechanism of why the oocyte quality is affected.
There seems to be a mitochondrial deficiency in these eggs, which is why early pregnancy losses seem to be.
No, you see that the shape is different. You see many a times perivitelline, this egg. And this is basically also related to the hypoandrogenism what the patient has, as well as the insulin resistance. So basically, they are related to both these factors, and therefore, looking at both these factors when you're treating a patient of PCOS is important. So when we talk about adjuvants, we know that you have a lot of them where you have mitochondrial nutrients. We can replace the mitochondria and also augment the mitochondria by using the stem cells. But what we use in our daily practice is basically coenzyme Q10. I have not used revesitol or alpha lipoic acid, but there are a few papers which talk about it, and minerals and vitamins also. So I'm not sure what is your experience, and if you look at the evidence which is there, maximum is there for coenzyme Q10. So any of you have any experience with all these?
Yes, ma'am. We always give coenzyme Q10 before starting patients on stimulation, even with PCO, because coenzyme Q10 may directly enhance mitochondrial function in these women.
And what about the dose of, madam, may I ask a question, like dose of coenzyme Q10?
300
What dose is
BD or
preferred?
300 once a day.
100 once a day.
100 milligram once a day will be sufficient.
300 once. I use 300 once.
100 twice or 300 once?
Once a day. Okay.
So now this is the second patient, and she's a case of who's a poor responder. She was 35 years old, married for 4 years. She's trying to conceive for 2 years. She had irregular cycles every 35 to 60 days. She was a known case of hypothyroidism since 8 years and was on thyroxine 150 micrograms. Ultrasound was done. Both ovaries were normal with volume of 11 on the right and 8.6 cc on the left. So wherever she had taken treatment earlier, they had not done the antral follicular count. They also did only the FSH and LH levels, which were quite normal. And despite taking thyroxine, one of the levels in 20 were significantly higher. But when they did her repeated her FSH in 24, it was significantly higher in almost 1.5 years. It was 13.8. Semen analysis was also not done, and basically no treatment was given to this patient. So I'm not very sure why they monitored all these levels, and they've not looked at the antral follicular count or AMH in this patient. So when we looked at her, her BMI was very high. It was 34.4. And if we looked at her antral follicular count, it was 2 and 1 in the left ovary. And even the ovarian volume was significantly lower. We did the semen analysis, and which was normal. And then when she came to us in the first cycle, the FSH was very high. So we did not do any, we did not stimulate her in that cycle. And you can see that the AMH also was significantly lower. It was 0.79. And apart from the TSH, her TPO also was elevated. But she was anyway on thyroxine. So we really did not give much importance to the TPO, what was there. And then after that, we did a hysteroscopy for her. And then she did not come almost for 1 year. And then she came after 1 year to us. At that point of time, her FSH was 7.48 and her AMH was 0.168. So as the FSH was high and AMH was low, the patient was basically counseled for oocyte donation, but the patient insisted on using her own eggs. So how would you treat this patient?
So first, we would start with pre-treatment with the use of coenzyme Q10 with resveratrol for at least 1 month if we have time. I would like to always choose the long agonist protocol because it has the advantage of giving us better follicular synchrony and better results with the fresh transfer if that's possible. And I would also like to give a testosterone gel for 20 days in the preceding cycle, starting from the 6th day of a stimulation.
There's no now evidence
Yeah, but the T transport trial, I believe that in the
has shown that there is no advantage.
I believe the dose
1.5 oocytes more, but it has not increased the clinical pregnancy rate or the live birth rate.
Yes, ma'am. But the dose I believe that they use in T transport was much lower than most of the other studies which have come out. So I think that is
I
still.
think they used the normal dose only. The study was done by Nicholas, and he had used the normal dose, what has to be used, because he was the prime investigator, and basically it was a multicentric trial. So they have shown that there's no advantage, and even DHEA has shown is shown to have no advantage and has not increased the live birth rates. Though there are 1 or 2 papers which have shown that DHEA has helped, and especially the network study by Zhu et al., which came from China, has shown that DHEA probably helps in having more number of oocytes.
Sensitizing the oocyte to hormones.
But the no other study has shown advantage of using DHEA.
Yes, ma'am. So another thing is that if I'm doing the long agonist protocol for this patient, I would also like to start with a higher dose of HMG with at least 300 international units of HMG in the long agonist protocol.
Anybody else has any different opinion on it? So basically,
I will like go for
because
it.
he wanted to try
Antagonist.
wanted to try IUI, not go for IVF. We had done her hysteroscopy and we had also done her intra-ovarian PRP when she came in 2024. After which we did an IUI in a natural cycle. She had a biochemical pregnancy. And then she came in August with a spontaneous conception at 6 weeks. And it was a twin pregnancy. And 8 weeks, she was diagnosed with missed abortion. We had done a suction evacuation, and one of the fetus had partial trisomy and the other had duplication of chromosome 12 at the 1q region. After that, after August, she came directly to us in January 25 for an IVF cycle. So how will you proceed now? What all would you do for her?
Patient has to be detailed counsel, value of how much is her realistic expectation with each egg she is getting. She has to be counseled. She may need multiple cycles of stimulation.
Pooling
for embryo
pooling
pooling.
embryos.
She may need.
Why should you do an embryo pooling?
We can go for
because of genetic.
If you look at the recent papers, poor responders are not patients who are subjected to PGTA. They
But
say
there
that
was
it's only the good prognosis patients where PGTA should be done in elderly patients who have a good ovarian reserve, because once you freeze the embryos and thaw the embryos, there are always increased risk of epigenetic changes, and the implantation rate is definitely lower in a frozen thaw cycle. And therefore, as far as possible, what you should do is a fresh embryo transfer.
This patient,
But
she's having
I think I would agree with my colleague, Dr. Avasti, that if the patient is not a candidate for a fresh transfer for whatever reason, and we understand that the trauma of a negative test repeatedly for some patients can sometimes be very difficult. So by giving her the option of embryo pooling, getting 2-3 good embryos, and then doing a subsequent
then
study,
go
it will give her a
for
much better
testing.
chance.
If she's
she's
going to
not
conceive,
complying to the
no,
treatment.
but if she's going to conceive with
Regular.
a fresh transfer, what you've done just with 1 or 2 embryos, then why are you making her spend more?
No, correct. You're absolutely right, ma'am. But I would say that in the few cases where fresh transfer is not possible, so let's say that her lining is too thin or progesterone on the day of HCG trigger is not right, then in such cases, embryo pooling can be given as an option.
This patient, she's not consistent with the treatment also. She'll come just like that. She'll go away. So if one cycle fail,
That's not a reason for doing embryo pooling, according to me.
Okay.
If she's not consistent with treatment, because anyway she doesn't want to go for egg donation, she wants to use her own eggs. So the best chances, if you look at all the evidence also which is there, they say that it's best to do a day 2, day 3 transfer in a patient who is a poor responder. And agonist protocol, as he said, is much better because it gives us more synchronous follicles, though you might require a higher dose of gonadotropins in these patients. And secondly, doing a oocyte retrieval at 34 hours rather than at 35 or 36 hours is much better, and a shorter culture outside. And if the semen analysis is normal, it's best to do an IVF instead of doing an ICSI for these patients. So what we did for this patient was that her FSH was 9.6. We had just done her in September, we had done a AMH, which was almost similar, but her progesterone and estrogen was normal. So we did an antagonist cycle for her, where I used a very high dose because her AMH was low, wherein I gave REC FSH at a dose of 150 and HMG 300, where that's the maximum dose which I use in my clinic. So we had 4 follicles which were more than 14 millimeters in size. Her E2 was 703. So probably it was slightly lower for the 4 follicles she had. Her progesterone was low on the day of trigger, but I had given her a double trigger where I used both HCG, REC HCG as well as GnRH agonist. We had 4 M2 oocytes. IVF was done 3, fertilized and cleaved. And on day 3, we transferred 2 embryos. One was stem cell, as you can see over here, which was grade 1, though there was no compaction which was seen. The other was a 8-cell embryo, as you see over here, which was again grade 1. Luteal phase support was given with both progesterone and HCG because I thought HCG would help her in having a better corpus luteal function. And beta HCG done after 12 days was 409, and which increased to 1,954 after 18 days. Once the fetal hearts were seen, I empirically started Clexin, though probably it's not indicated in her, but because of being a poor responder, I did start. Now she is about 18 weeks. We've done both NIPT and amniocentesis for her to rule out any aneuploidy, and the karyotype is normal. So as the patients can go for oocyte donation at any time, should we do day 2 FSH levels every cycle for about 6 months before really we go for oocyte donation in these patients who have a high FSH level? Because many patients, I had another patient, basically, she used to come to me, she used to take progesterone. Her FSH was very high. If she didn't get her periods with progesterone, she used to take oral contraceptive pills and come every second day. And I think we targeted 2 or 3 cycles for her when she had a low FSH. And in one cycle, she had a biochemical pregnancy. In the second cycle, her follicles ruptured despite she was on long agonist protocol earlier. And in the third or fourth cycle, she did conceive, and she was almost 42 years old. But she insisted, I think, on using her own oocytes. So I think even the mindset of a patient is very important when you're treating her. If she has a positive mindset, it really helps her in conceiving. But if she has a negative mindset, that also defends her from not conceiving.
Ma'am,
So,
I have one interesting question for you here. So when you're counseling the patient at the outset, like in your experience, what is the maximum number of cycles you would let her attempt before you say, okay, you know what, we really need to stop?
four cycles.
Okay.
Yeah. There was another patient of mine. I mean, it's this out of the contest. She had undergone 3 cycles outside, and she had also undergone 3 surgeries for endometriomas outside when she came to me. And she did have a hydrosalping. So when she came to me, I said, no, let's do the clipping of the hydrosalpings and then go. So she was not ready because she had undergone so many surgeries. So in the first cycle, we did at least 2, in the first 2 cycles. She also had a low ovarian reserve. So in the first 2 cycles, she did not conceive. In the third cycle, when we did, then she had fluid in the cavity. So we canceled the cycle. And then we froze the embryos. Then I told her, see, this is because of your hydrosalpings. So at that point of time, then she agreed. So we couldn't see the tubes at all because they were totally plastered. So what we did was just disconnection of the tubes at the cornu, and then then we did the frozen embryo transfer. But at that with that cycle also, she did not conceive. And then in the next cycle, I did a long agonist protocol for her. And we got, I think, 4 oocytes, and we had 2 blastocysts which we transferred. She conceived with twins. I think the twins must be now at least about 15 years old now. So there are patients, who are so positive. That's what I'm trying to tell you. Like the other patient also, which I told you, who was 42 years and having high FSH levels. And she came religiously, she came for almost 1.5 to 2 years on the second day of her period. So I think the mindset of the patient also is very important. And also
Yes, ma'am.
how you counsel the patient is important, because any new patient who comes to me, when I look at her old papers, I look at everything, I talk to her almost for 45 minutes. So my consultation with a new patient is almost for an hour. So I think that also makes a difference. So I would like all of you all to give me an opinion on this. That would you not do an IVF for her, or would you straight away say, no, nothing will help you and you'll go for egg donation? So
No, ma'am, I agree with you. As long as the woman is not menopausal,
Yes,
if
yes,
she's
ma'am.
motivated, I would give her a fair chance. But then the
Yes.
only question always is when to stop. What is the upper limit?
Yeah, so that the patient has to decide.
Yeah.
That depends
Yes.
upon
We
the
can just
patient
tell
Yes,
her,
ma'am.
individually.
but I think the patient needs to decide on that. So is there any role of any adjuvant therapies like clomiphene and letrozole with the gonadotropin so that you reduce the dose, and the role of double stimulation? We have already discussed the role of DHE and testosterone,
DHA testosterone.
and CoQ, but we need to discuss the role of growth hormone. And as I told you, the minimal and mild stimulation, that is where we are using clomiphene citrate and letrozole. So go on. Whoever wants to answer.
No, ma'am, I would not use clomiphene or letros in my stimulation protocols. I would either first start the long agonist protocol, and if that does not work, I would use high dose antagonist cycle in the next round, but not with clomiphene and letros. I think minimal stimulation originally was developed to keep cost into consideration, so that patients can do multiple cycles, keeping the costs down. But I think even in SJ 2023, the unanimous conclusion was that high dose stimulation and trying to accumulate as many eggs as possible is probably the best route forward.
So there are studies where they've used clomiphene and letrozole. So that basically does not increase the clinical pregnancy rate or the live birth rate, but it definitely reduces the dose of the gonadotropins that is required. And same is that with growth hormone. So there are studies which have shown that it definitely does not increase the live birth rates, but it definitely reduces the gonadotropin dose. There was one study which had come from Taiwan by Dr. Chiri, wherein he used growth hormone and just the dose of 4 international units. He used it from day 2 or 3 of the cycle in this group, especially in those patients who had repeated implantation failure, just for 5 days or 6 days. And according to him, in his paper, he says that just giving growth hormone, it's not only for improving the ovarian response, but according to him, it helped in improving the implantation rates in that group of patients. But I think that study didn't have that many number of subjects, but probably you can, read it because he practices that for almost all his patients, wherein he just uses 4 units for 5 or 6 days.
Yes,
So
and I have used this in poor responders in my practice. What I have observed with growth hormone is that you don't require a longer duration of stimulation in poor responders and with a good dose of 450. But yes, once the cohort is selected, then I stop the growth hormone after 5 days of usage.
yeah, basically it only reduces that's what I said, it reduces the gonadotropin usage, and it probably helps. So these are just the Poseidon, how you treat them. I just don't want to go. But in the Poseidon 3 and 4, I think when you have a higher AMH, they definitely give you better more number of oocytes, more number of M2 oocytes, as well as utilizable embryos. So even in that group, you need to select you need to counsel the patients according to their AMH levels. So this is a case of endometriosis. She was a 35-year-old. She was married since 7 years, but she was only trying to conceive for 6 months. She came to us in 2023 with primary infertility. She had regular menstrual cycle and coital frequency. There was no relevant past history. The HSG done before she came to us, both the tubes were visualized throughout their course with minimal spillage, which was seen bilaterally. And on ultrasound, she had a left endometrioma, which was almost 6 centimeters. There was no mention at that point of time on the antral follicular count and ovarian volume. So they had so basically the FSH was 5.87 and LH was 5.14, but the AMH only was 1.1. TSH was normal. The semen analysis was normal, and the past she had not taken any treatment. So we know that FSH really increases only late in the in your
Process of depletion of the
menopause.
reserve.
Yeah. So basically it is AMH, which is it's a more sensitive
Sensitive
marker.
marker.
So
And the earliest one.
So she had a BMI of 23, though her waist hip ratio was 0.94. That is, she had central obesity. Otherwise, most of the findings were normal. And on the day she came to us, I think it was premenstrual, so her endometrium was 19 millimeters. And
Hyperestrogenic.
she had 4 small follicles on the right, and she had 2 small follicles on the left, and she had a large endometrium on that side. And when we repeated her AMH, it was 2.3, and her TSH was very low. We repeated her HSG because there was a minimal spill, because again, she did not want to go for an IVF immediately. The cavity was normal, though there was ampullary coiling seen on both sides. There was good bilateral spill which was seen, and the tubes were reported as being category 2B. So then, should you go for a laparoscopy before you attempt any treatment in this patient?
And so, if the patient is desirous of having babies, I think this is, of course, a very classic controversial case. But I am of the faction where I believe stimulation should be offered very seriously to this patient before going in for surgery, especially if she wants the possibility of having babies in the future. Because no matter how perfectly we do an endometrial cyst resection, there will be a lot of normal ovarian volume and tissue which will be removed during the surgery. And we've seen a lot of cases post-op where the AMH crashes, and a lot of these women have a very, very poor response in the future. So offering stimulation, first freezing eggs and embryos, then maybe going in for surgery is, in my opinion, the ideal way to go about it.
Yeah, especially when the ovarian reserve is very low. So that's
35 and ovarian
Ma'am,
reserve is
also important point to
tubal
note on
disease there.
sonography is that whether the ovaries, how accessible are the ovaries, if there's any distortion of the anatomy, where the normal follicles are placed around the endometrioma, because there are high chances they are placed peripherally. You may during the pickup go through the endometrioma and there are increase the risk of an abscess. And
Yeah.
if there are any simultaneous symptoms of severe dyspareunia or dysmenorrhea, then definitely in such situations, surgery can improve her standard of living, and then we go for stimulation.
No, but then it's going to reduce her ovarian reserve further. Now she hardly has any follicles. In this patient,
Correct,
I
ma'am.
don't
Surgery
She
think.
has
only we should go for
only,
surgery
yeah, so
before, like
only
when
if
the endometrioma is coming on in the way of the
the
follicles,
way,
and there's
yeah.
a high risk of puncturing the endometrioma while we are doing a ovum pickup, or the endometrioma is large enough so that the normal follicles can't grow there. So
So
that is one
There's no
indication
element
I
of
part.
absolutely
pain.
agree
Follicles
with
can grow with an endometrioma. There is no problem in the follicles growing with an endometrioma.
I
And
absolutely
you have
agree with Dr. Aditi,
Sometimes they
where
are
if the
compressed, ma'am. We have seen that is a like practical thing we go through. Like it's such a huge one that it is going to compress all the follicles in the periphery. So that is the, in fact, I have seen one in my OPD today with a huge
That's what I was telling
endometrioma.
you about that other patient, which who had undergone 3 surgeries before and this thing. So I, in my practice, if the ovarian
No,
reserve is
that is
still
the
less,
last resort. That is not the first thing,
no.
madam.
That's what I'm trying to tell you. In my practice, if I have a endometrioma and I cannot access the this thing, and she has such a low ovarian reserve, I prefer doing a transvaginal aspiration of the endometrioma, followed by a single injection of a depot preparation.
But
Though many
but
of them
that
say
is the
that it should not
evidence.
be done, but in my practice,
It shouldn't be done, ma'am. It has high risk
my
of
practice of
causing ovarian
35,
abscess.
35 years, I've not had a single abscess.
I know,
Ma'am,
ma'am, but again, if we're talking about
one,
recommendations and things, then
No,
this is an
no,
absolute
recommend.
no.
No, but then if you see the newer papers, they also recommend doing an
So that is
aspiration, especially in those patients who have a low ovarian reserve. I can send you the paper.
ma'am, I just one case was an eye opener for us in our practice. There was a pickup done from a peripheral center. I would not like to name the
yes.
center, wherein patient came after 15 days of oocyte retrieval with severe pain in abdomen. No history of fever, counts were marginally
Yeah,
raised.
but that
No
also depends
sufficient
upon, see,
dietary
again,
bad
Exactly,
it
ma'am. You
depends,
can do
no.
that, but not everyone is
Yeah,
like
yeah, everybody
well
cannot do,
versed with
but
the
it
procedure
also
or
depends
experienced
upon
enough.
how
With your,
good you are
yes, ma'am.
at a this thing. So if
Yes,
you
with
ask
your
me,
35 years
I do my
experience, you can do
aspirations
that.
in 5 to 8 minutes, but
That is
everybody
what,
cannot
that
do in
is,
5 to 8 minutes.
yes, ma'am. That is what, like, my point was to highlight that
if it
because
is
not
done in best hands,
everyone
ma'am,
is as experienced as you.
if the pickup is done by best hands with good experience, we can definitely avoid an abscess. But this
Yes,
thing has
yes,
to be kept in mind
Yes.
that don't just
Yes,
directly
it
yeah.
has
start
to
We
be
have to
treatment
kept as
without a
counsel
far
at
as
pickup.
least.
possible. You should not
Yes, ma'am.
touch the
That was the only
endometrium.
point I wanted to highlight.
If I may, the last point I'd like to add here is that I would agree with Dr. Aditi, especially if the ovaries are not accessible, where
But
I
then you have
propose.
to do a surgery. You have
Yeah,
to
but
do
even in the
Yeah.
surgery, we can first do an adhesiolysis, get the ovaries in place, then stimulate before we actually remove the ovarian
But
cyst.
in such cases, I've done abdominal pickups.
Ah, okay. But
Yeah,
again, adhesions
laparoscopically
is very
pickup
difficult
also.
if there are
Not
too many adhesions.
laparoscopic, trans,
Oh,
with the transvaginal
Transabdominal.
pickup. So now what we did with this patient, so in the first cycle we gave her she didn't want to spend much, so we did stimulation with CC. We had 2 follicles in the right lobe. There was no pregnancy. Then she didn't want to go for a laparoscopy. So as I told you, I did a cyst aspiration for her. We gave her 3 doses of GnRH agonist depot preparation. And then we went for stimulation because her AMH was 2.8. So we first started with, because she had a low, we started with only HMG 450. We gave for 5 days. There was no follicular growth. So then I changed it to 150 and 300. And on day 12, we had 6 follicles more than 17 millimeters and 2 follicles 14 to 15 millimeters. The E2 was 2572. We gave a HCG trigger. We had 8 M2 oocytes, 8 fertilized and cleaved. And day 5, we had only we had 2 embryos transferred. One was 3BA, as you can see over here. The inner cell mass was not good at all. And the other one was totally expanded. But again, the inner cell mass was not good. And out of those 8, only 2 became blastocysts. The remaining really did not become blastocysts. Luteal phase support was only with progesterone, and she did have a biochemical pregnancy where the first level was 68, then 166, then 258, and then 333 after another 5 to 6 days. And because it was not rising, we stopped the progesterone, and then we monitored her till her HCG levels came down. Then we went for the next cycle where we used the antagonist protocol, where we gave here, because she didn't respond only to HMG, we gave her REC FSH 300 and we gave her HMG 150. She had 8 follicles, more than 17 millimeters, and 6 follicles, 12 to 14 millimeters. E2 was almost 3,100, and we gave her agonist figure, 12 M2 oocytes, 10 fertilized and cleaved. Day 3 embryos we did transfer because she didn't want to go for frozen embryo transfer. And we kept rest for blastocyst culture, but none of them became blastocyst, and she did not have a pregnancy.
We didn't go for ICSI, ma'am. It was all IVF.
Yes, IVF. I do IVF only if the sperm count is normal. I don't go for ICSI.
Okay, but
One of my patients is subject to ICSI. Yeah, tell me.
But some papers they say like in endometriosis because the
No, but
zona
now
is hard.
if you look at the newer this thing, if you have a good and in my experience of 35 years, I do embryology also, because when I started my practice in 94, there were not there were no embryologists which were really available. So I used to do my embryology myself. So according to me, I have seen, at least in my practice, that it really does not make a difference unless it's a male factor or there is some other factor where we really require ICSI, then only we go for ICSI. Otherwise, we prefer doing IVF in all our patients, even if we have 2 or 3 embryos. Like I had another one, that's what I was going to tell you also about this. I'll tell you about this case and then I'll tell you about the other case. So we gave her depot of preparation for 3 doses again because she had conceived last time. This time we gave her Pergovirus 300 IU. For 8 days, she had 5 follicles 17 and 2 follicles 14 to 15. E2 was 1900. We had 5 M2, 4 fertilized and cleaved, and day 5 she had 2 blastocysts. And you can see that there were only grade 2 blastocysts. We gave a luteal phase support of both progesterone and HCG, and she had a twin pregnancy because the first level was 581, and after 4 days it was 2000. We started Clexin after OPU empirically again, twin gestation, but one twin vanished at 9 weeks and she delivered a female child 2.8 kilos. So that's what I said. So it is not only the embryo, but the endometrial receptivity also is very important. I had another patient, she also was a case of endometriosis, and her ovarian reserve was poor, her AMH was 0.8, and we use the long agonist protocol. We got 3 oocytes, only 2 were M2, and only 1 grade 2 blastocyst we had, and we transferred that, and yet she conceived with that. So basically, one must realize that it's not only the embryo quality, but even the endometrial receptivity, which is important. Monica, I can continue. I'll stop.
Ma'am, we have time if you want to finish something. I mean, you're most welcome, ma'am, to continue.
No, I have 2 more cases, but in case you want me to stop, I can stop also.
No, ma'am, it's okay. It's okay. You can continue.
So do you think that patients of advanced endometriosis, we should go for IVF earlier than keeping on doing IUIs?
In grade 3, grade 4, definitely, ma'am, IVF is going to help them in a better way because the ovarian reserve is good and we can get good
But
amount of
we also have to
embryos and
consider
we
the
can
age of the
select.
patient. So if she's very young and if
Yeah.
it's a very advanced endometriosis, of course, we can give her some time. But if she is already in her early to mid 30s, then I think IVF should be the first option of choice. Age, I think, and the grade of endometriosis should be the most
Grade is also very
determining
important.
Male
If she
factor,
already
if
has
male factor is there, severe male factor, then
or
also we
multiple
have to
factor,
consider it.
exactly.
Like I
So
had a
age and
doctor
grade of endometriosis and some other factor is there, like associated, multiple factors, then definitely ART, IVF is going to help the patient in a
Previous
I'm
better
sure
way.
multiple
you have
surgeries.
surprises coming to you. Like I had a doctor who had grade 4 endometriosis. Both her tubes were totally engulfed, and her endometriomas were almost 10 centimeters on both the sides. I basically did the surgery for her, And then I gave her 3 doses of GnRH agonist. And after she finished, she said she doesn't want to undergo the IVF immediately. She said she'll come after 4 or 5 months. And then after 2 months, she came with a pregnancy, and it was a spontaneous pregnancy. Though I thought it can never, I can show you one of the pictures. It was so bad, her endometriosis. So there are certain surprises we get from our patients, wherein they come with conception when you feel that they are not going to conceive, or many times those patients who have failed IVF with us and they come with spontaneous conception. So I think when you are relaxed, you always try to, the chances of having a spontaneous conception are much higher. So when you're giving COS, do you have any limit whether you would cancel the cycle in these patients of endometriosis, or even if you have 1 or 2 follicles, you would go ahead and do IVF?
Again, I think counseling is very important, but we
Counseling,
have
yeah,
to
and what
inform
the patient wants, that is
every
also
egg
very
has the
important.
potential for life, and these women have only so many chances
Yeah.
because most of them will be poor
So
responders.
some of them
I
will
would go
have
ahead.
only 1 or 2 follicles,
Yeah, I would still
like
go ahead with the IVF.
whatever kind of a stimulation we give. So I think we should counsel them and we should go ahead as per patient's wish also.
I give them a realistic guarded prognosis, but going ahead is very reasonable.
So as I said, embryo development and implantation is totally different, even in poor reserve, as we said, that if you have a good endometrial receptivity, you can go. So this is a patient with endometrial carcinoma. She was 30 years. She'd come with secondary infertility. For 2 years, she had a blighted ovum. Soon after marriage, she had irregular cycles. She was hypertensive on medication. She had undergone 3 cycles of ovulation induction with CC. And E2 was added vaginally in all cycles. And the cycles were really not very well, they were not monitored at all, I think. And there was a history of diabetes in the family, and the grandfather had lung carcinoma. Her BMI was 26.4, AMH was 3.4 in 22, and then in 23 it was 2.24. All the other tests were within normal limits, but though the count was okay, the rapid progressive sperms were only about 15%. HSG showed bilateral spill. When she came to us, it was cycle day 11, and she had antral follicular count of 8 to 10 in the, I think, left ovary, and that of 15, and that of, I think, 8 again in both the ovaries. She had adenomyosis. She also had calcific spots in the myometrium. The endometrial thickness was 5.7 millimeters. It was ill-defined, isoechogenic, and we thought that probably she had adhesions when we did the 3D scan. And on cycle day 15, basically, she had a dominant follicle, which was 19 millimeters. But the endometrium still remained thin and ill-defined. So we did an hysteroscopy for her, where she had multiple small follicles which were present, and that was sent for histopath. And it turned out to be endometrioid adenocarcinoma grade 1. And she was ERPR positive, P53 wild, and MMR proficient. So basically, to know the HR, the hormonal status and molecular profiling, is it important in patients of endometrial carcinoma?
Yes, ma'am. I think it is because during stimulation, you would want to try to keep the E2 levels as low as possible because there is some concern of a flare up. So there was a beautiful Chinese study which recently showed that you can use letrozole or tamoxifen during stimulation. And what they found is using letrozole 5 milligrams along with your
I'm
gonadal.
asking you about the molecular profiling. Is it important?
Apart from the stimulation, molecular profiling
From
is important
stimulation
for the
point of view.
prognosis of the patient, whether she's
From the
fit
stimulation
for
point of view,
fertility sparing surgery.
no, the stimulation point, whether your molecular profiling is important.
If she's hormone resistant.
Yes, madam.
Yes.
Yeah, if she's positive, then
Yeah,
it.
so what all you look in the molecular profiling? HR status, you've already said. I don't want to know about HR status, about the molecular.
P53 will be checking.
I can't hear.
P53, madam.
And what
We
else?
are.
A poll status can be checked. Then two more molecular markers are there, apart from estrogen receptors. One more marker is there.
So basically, ERPR is important because it will tell us about the treatment, and you have to use something to keep the levels low, and even the progesterone basically is the treatment. So molecular profiling, basically what we look at is the PROMIS molecular classification and the immunohistochemistry for identification of MMRD or P53ABN tumors is mandatory. For MMRD tumors, basically, especially when you're suspecting Lynch syndrome, it has to be identified because you have to do appropriate counseling because they have also a risk of developing additional cancers. And a tumor which has MMRP and P53ABN phenotype should be tested for pole mutation. And if it belongs to a copy number which is having a high molecular subgroup, then conservative treatment is inappropriate for this patient, and therefore fertility preservation, even if she is grade 1, should not be done. And that's what there was other studies also which have shown that it is associated that the prognosis is worse when they are of P53 WT subtype, and also they have the shortest time to progression or for definitive therapy, and therefore whatever you do, you should do at an earlier stage. So basically, pre-treatment MRI for metastatic disease, our myometrial invasion was done. The growth was about 1.5 centimeter, but there was no invasion in the myometrium. The lymph nodes were not enlarged. So fertility sparing treatment was advised. So we gave her Megestrol 130 milligrams for 6 months. 2 consecutive endometrial biopsies, 3 months apart, showed simple hyperplasia and a small focus of complex hyperplasia. She could be allowed spontaneous conception, but ART, we know that reduces the time to pregnancy. So decision was taken to go for IVF. So how will you stimulate her?
The choice.
So random stimulation can be considered,
letrozole.
especially since we don't have time. So you don't have to wait for the second day of a cycle. You can start treatment immediately on any day of the cycle. And to keep estrogen levels low, I would like to give her letrozole along with
and along with moderate stimulation with gonadotropins.
And always use the agonist trigger because we cannot afford OHSS in such patients.
Anything else? Anybody else wants to say anything?
Ma'am, you would want to use letrozole or tamoxifen when you're stimulating this patient so that the estrogen levels can be kept at minimum and
under control. Yeah,
may
there are
continue letrozole.
studies that I will discuss even in my next case. Though both letrozole and tamoxifen keep the levels low. And if you go to see the number of M2 oocytes which we retrieve when letrozole is used is much less. And this is because the follicular fluid is much higher. So then there are studies which have shown that the threshold value of the follicle at which you trigger has to be much higher when you're using letrozole as compared to tamoxifen. And even if you look at the ASHRAE guidelines, which are not for endometrial cancer, but they're basically for breast cancer, they prefer to use letrozole because the E2 levels
with
are
gonadotropin.
Lower with letrozole as compared to tamoxifen. Though if you look at the number of oocytes retrieved, number of M2 oocytes and the live birth rates are almost similar. But tamoxifen has not been tested in randomized controlled trials as compared to letrozole, which has been tested, and therefore people still use letrozole.
Tamoxifen has an agonistic action on endometrium and uterus.
No, it can be used, but so these were her levels. So we used antagonist protocol where we used FSH 75 and HMG 75. Letrozole we gave 5 milligrams from day 3 to 7, but then we also continued later. The E2 on day 8 was just 182 picograms, and FSH, so we increased the FSH dose to 150 Day 11, most follicles were between 13 to 14 millimeters. So we also increased the HMG dose to 150. And on day 14, we gave the trigger with HCG when 3 follicles were more than 18 millimeters and 3 were between 12 to 15 millimeters. The E2 was 1000 at that point of time, and progesterone was low. We got 6 oocytes, 5 fertilized, 5 cleaved. Luteal phase support was given by progesterone. We transferred 2 blastocysts, 4 AA, and the other one was 3 AB. 10 days, her beta HCG was positive. The second level also increased. Pregnancy was confirmed, and she had a full-term delivery. So this patient, she desired another child. So we then put an LNG IUD. She came after 5 years for the second pregnancy. The LNG IUD was removed. She had an antifollicular count of 3 in both ovaries. So that is a total of 6. AMH had reduced further to 1.1. So we stimulated her with HMG 300 IU in an antagonist protocol. As you can see over here, again, letrozole was given to her to keep her E2 levels low. On day 6, we started the antagonist. Trigger was given when 4 follicles were 18 and 2 were between 14 millimeters. The E2 level was 1300. We had 7 oocytes, 6 fertilized. Day 5, we had 2 blastocysts, 4 AA and 3 AA, which were transferred, and 1 blastocyst, 3 AA was frozen. Luteal phase support was with progesterone, and beta HCG was negative, so we discontinued the progesterone. So what are the different protocols that can be used for a frozen embryo transfer in this patient?
Natural cycle if she's ovulating.
Natural cycle, yeah,
Natural cycle.
definitely. Natural cycle will be the preferred method. Otherwise, we can give a mild stimulation with
minimal stimulation with letrozole.
With letrozole. Ovulation induction protocol can also be used.
Okay. So basically, and also the other protocol, so we can use any protocol, agonist, antagonist, or we can give a HCG or a dual trigger. Basically, to keep the E2 levels, we have letrozole can be used because most of the studies for letrozole and tamoxifen are in breast cancer patients and they're not in endometrial cancer patients. But today, we still use letrozole to keep the E2 levels low. We can also use the PPOS protocol if we are not going to do a fresh transfer. And we can also do a control ovarian stimulation with LNG IUDs in C2. And it has been shown that none of them had a negative impact on the cycle performance, including total mature oocytes, total oocytes retrieved, mature oocytes, clinical pregnancy rates, as well as live birth rates. Then when you're preparing, you can use either of the protocols. And FET, you can also use an artificial or a HRT cycle because you require less monitoring and it is easy for scheduling. And because you're going to use progesterone for luteal phase support, basically it really did not increase the chance of the patient having a recurrence of the endometrial carcinoma, and probably an HRT cycle also can be used. And in this patient, basically because we had put an LNG IUD, so she had progesterone almost for 5 years because she came to us only after 5 years. So the progesterone effect was there, and therefore the chances of having a recurrence would be very low.
Yes.
So we did an HRT cycle because this patient, she had come from, she was not from India, she'd come from outside. And then she did not have time to go for a natural cycle. And if she didn't ovulate, then to go for an HRT cycle. So we did an HRT cycle where the maximum dose what we gave was 2 milligrams 3 times in a day, because we normally start with 2 milligrams twice a day for 4 days, followed by 2 milligrams thrice a day. On day 14, when her endometrium was 9 millimeters and triple line, we started progesterone. And then on day 5, we transferred a hatched blastocyst, which was 6 AA. And she had a positive HCG and she also delivered. She's still not undergone a definitive surgery, though we've told her to undergo a definitive surgery. So I don't know why she's delaying the definitive surgery. And the other thing what we need to keep in mind when we are seeing patients of endometrial carcinoma, I can tell you two other patients. So we had one patient who had who was both the patients, the other two were PCOS patients. Both of them had an antral follicular count of more than 20 in both the ovaries. But the first patient, which I'm going to tell you, she was obese. She also had hypothyroidism, she had hypertension, and she had impaired glucose tolerance. In between, she had developed, she had low platelet counts, and then she developed anemia because of menorrhagia. She was given transfusions, and then when she came to us, she also had a metabolic syndrome. We did stimulation for her, but all her eggs were of poor quality. All of them had perivitelline spaces. They had large vacuoles in the oocyte. Though we did a fresh embryo transfer for her because her E2 levels were kept low by giving letrozole, she didn't develop that many follicles. I don't remember now how many eggs we got. I think there were 8 or 9. But the quality of the embryos was also very bad, and she did not conceive. After that, she came for one more cycle. The similar thing happened in the next cycle. And again, she didn't come for a year. After that, she came, and when we did a endometrial biopsy again, she had developed endometrial carcinoma, and then she went for definitive surgery. Whereas I had another patient who also was PCOS, but she did not have any metabolic syndrome. So she conceived in the first cycle. We had frozen the embryos. We did a frozen embryo transfer, but she did not conceive. After that, she came again for a fresh cycle, and she didn't conceive in the fresh cycle, but then she conceived in the frozen cycle after that. So I think, especially, we know that endometrial carcinoma is more common in patients who have a polycystic ovarian
Ovarian
syndrome.
disease.
So basically, having metabolic syndrome decreases their chance of conception. And all patients who have PCOS who come to you and who have a thicker endometrium on day 2, I think all of them should be tested for endometrial carcinoma. So anyway, this also we have discussed. So is there this thing concern about relapse after you give her control ovarian stimulation? So what is the risk of relapse in these patients?
Studies have showed that the relapse rate is very less if you are keeping the estrogen level under control.
No, I'm asking you, there is a relapse rate. So what is the relapse rate?
30%.
And some studies have even shown around
17 to
relapse up to
30%.
50% after COS.
Pardon?
It has shown relapse up to 50%. Certain studies have shown relapse up to 50% after control ovarian stimulation in patients with carcinoma. So that counseling needs to be done. So our idea is to get her pregnant as soon as possible and directly plan surgical management as soon as possible once fertility is achieved.
17 to 30% is the relapse rate.
Only one study has shown 50%, but most of the studies have shown about 25%. And it has been shown that if you're using a LNG IUD, the recurrence rate is only 12% as against 30% in those patients where you have used only oral progesterone. And basically, the relapse also will depend upon the age of the patient, the treatment time for the endometrial lesions, because if you've done the first endometrial biopsy and then you've given megestrol for 3 months and you do the repeat endometrial biopsy and you find that there's total regression of the cancer, then the chance of relapse is good. But if the time taken for regression of the lesion is more than 6 months, probably the chance of relapse is much higher. And therefore, it's important to keep your E2 levels low on the day of trigger. And it's also look that if you take a longer time for gonadotropin stimulation, then again, the chance of recurrence is much higher. So do you want to go, or you want me to stop? I can stop also. Monica?
Ma'am, it is up to the panelists.
Yeah,
Ma'am, if we can just discuss few take-home points when it comes to
Yes,
breast
ma'am.
cancer,
Yes.
I think that will solve the purpose.
Yes, ma'am.
Yeah. So this, she was a 28-year-old patient with breast cancer, which was ER/PR positive. It was HER2 negative. BRCA mutation also was negative. So they had done a wide excision, lumpectomy. So post-surgery, they had planned for tamoxifen, but with radiotherapy. So therefore, she was referred for fertility preservation. So basically, what technique you would give and how would you evaluate the patient prior to starting the control ovarian stimulation?
Random start stimulation we can do depending on the time
I'm
available.
asking you first the technique, yeah. You see the questions, then you tell me random start and this, and you how would you evaluate the patient before starting COS?
Ma'am,
We
first
have
of
to
all, we will see
do
the egg
PET.
reserve and everything. She's a 28-year-old, so we can offer egg freezing rather than. And if it's an adolescent girl, obviously we may think about OTC, but OTC doesn't have very good, not very good success rate so far.
No,
But we can do.
OTC, the success rate is good, but in India, we really don't get the
It's less.
media, so we
Yeah.
really cannot do it. So in India, basically, it's oocyte or embryo freezing, which should be offered to our patients. So how would you evaluate
Maybe
the patient before starting the control ovarian stimulation?
first of all, it is very important to be coordinating with the onco team that how much time we are having right now. Whether we have a good 1 month time, then we can even plan a proper stimulation, or then we do random start stimulation. Obviously, we evaluate the ovarian reserve, what is the AMS, and accordingly counsel the patient.
Yeah, so, and most important is the oncological status, which, as you said, and also the fertility risk assessment as to which treatment is going to be given. And even she's given the radiotherapy. Nowadays, they give they have those molds made and they just give it only to the region where it is required. So with that, the chances of decrease in the ovarian reserve is much less. So her antral follicular count was 10 to 15 in each of the ovaries. AMH was 4.8. Her BMI was 20. So what stimulation protocol would you follow for her? What dose would you give?
Antagonist protocol, we
150.
can be aggressive with the dose
150.
if you use only the agonist trigger, because you will of course be freezing all. There's no question of fresh transfer. And PPOS can be offered in such patients because again, we won't be doing a fresh transfer.
How can you do PPOS now? She's ER/PR positive.
Okay, yeah, correct. So it'll be
But
stimulation with
we
letrozole.
can
It'll be an antagonist protocol
Letrozole
when the
plus
T2 level is low, and the
gonadotropin.
agonist trigger.
So what? How would you prevent OHSS?
And with the agonist trigger,
By
OHSS
giving
won't happen.
agonist trigger.
And even if so we don't need to add anything after the agonist trigger.
Yeah. So
we
basically,
can continue letrozole post pickup till the estrogen levels come down to 50.
It has to be continued post trigger. So that's how it has been used. And one could also go for double stimulation if you have
double stimulation
post surgery, so that you have more number of oocytes and embryos that are stored. So we gave her 225 IU of gonadotrophins, and letrozole was given continuously from day 2 of the cycle. We gave her agonist trigger. Her E2 was 2000 because she was a case of PCOS. Basically, we had 16 oocytes, 14 M2, and basically we cryopreserved 9 day 3 embryos. The remaining were kept for for blastocysts, but none of them developed blastocysts because only 9 of them were of very good quality. So whether we were discussing whether one should use letrozole or tamoxifen to keep the levels low. So basically, this is what was seen, that with letrozole, basically there are less number of M2 oocytes because it impacts the follicular microenvironment and is also associated with altered oocyte morphology, because this was from one of the patients. And tamoxifen also can be used because it's normally used as a agent to prevent recurrence of breast cancer. So it can be used during stimulation. And it has found that it does not affect the number of COCs that are being retrieved in the patients of breast cancer. So so it has been seen that in letrozole cycles, the antral space is formed earlier, and the trigger criteria therefore should be extended by 2 to 3 millimeters, as I was telling you.
Millimeter.
Reach the same oocyte maturity rate that is seen with the standard protocol, and highest maturity rates were obtained when you give a trigger at 20.4 millimeters. Early trigger may be the reason of less M2 oocytes, and endometrial thickness is significantly lower throughout, but it's within the normal range. So when in this study, they compared tamoxifen and letrozole, and you can see that the peak E2 levels, the total number of follicles as well as follicles more than 17 millimeters, mature oocytes, and total embryos were significantly higher in letrozole, but in none of them the cycle was cancelled. So it was concluded, especially in the ASCO guidelines, that letrozole is better than tamoxifen when we talk about the number of oocytes retrieved, the M2 oocytes, which were much lower with tamoxifen. But this study in 2022 has shown that there was the number of oocytes retrieved and the embryos banked were not affected whether you use tamoxifen or you use letrozole. As you can see over here, the number of M2 oocytes as well as the number of embryos stored were almost similar. But only advantage is that the peak E2 levels are much lesser with letrozole as compared to tamoxifen. And the ESHRE guideline says that it's better to use letrozole, and they do not really recommend tamoxifen because we have limited data on use of tamoxifen during stimulation for breast cancer patients. So, how does the hormonal status get affected by the stimulation protocols, and does the cancer get worse with COS?
If ERPR is positive, so the cancer cells are sensitive to the hyperestrogenism and progesterone, so the COS may affect the cancer lesion.
That is why we are using letrozole, no?
Letrozole.
So basically, it has been seen that there's no significant difference in those patients who are stimulated and non-stimulated in cancer recurrence, and the cancer-free survival period was also similar, and basically it did not affect the recurrence or the mortality in these patients. So basically, she after 5 years of tamoxifen, she was cleared for pregnancy. But she didn't want to go straight for IVF, so she went elsewhere where she undergone 2 cycles of ovulation induction with letrozole with IUI, but the outcome was negative. Then she came to us for using the cryopreserved embryos. We did the monitoring, and when she had a corpus luteum in the left ovary, basically we did and the endometrium was 9, we started the progesterone. So after chemotherapy is over, what is the oncological follow-up advised in these patients? So you need to look at the various systems before you advise for pregnancy. Apart from the uterus and the cervix, as well as the ovarian reserve, you also need to look at the cardiovascular and basically the cardiopulmonary function is very important in these patients who have breast cancer. So if the risk of recurrence is high, as per genetic testing, would you allow for a pregnancy?
Yes, counseling is important and it's the patient's decision because quality of life is also the right to have our own biological child. So it's up to the patient to decide, I think.
So whether she should have gone for ovulation induction after completing her cancer treatment, or she should have come directly for using the frozen embryos?
She should have come for using the frozen embryos because that will
And what are the chances
shorten the time period.
Spontaneous pregnancy after breast cancer?
Upon the type of chemotherapeutic agent she used, whether it was gonadotropin
because
toxic or not.
But you normally don't use, depending on.
But cancer per se decreases the reserve. There are many cancers which, like, even if we don't go for a
But
chemotherapy,
she's BRCA negative. Only if she's BRCA positive, her ovarian reserve would be less.
reserve will be.
I think because chemotherapy can cause other DNA damages to the oocytes, maybe using the frozen embryos before chemotherapy would give a better chance of getting a healthier baby. But again, of course, I'm not basing this on
Before
data.
chemotherapy. Normally,
No,
unless
after chemo. After chemo also she
unless
can.
it is triple negative, we really do not give chemotherapy. These patients after surgery are monitored and just given tamoxifen. And now there was a study which has been published, which is called as a positive trial, where first it was said that we have to wait for 5 years after surgery, and 5 years you have to take tamoxifen before you go for pregnancy. But the positive study has shown that you can stop tamoxifen 2 years after you've started, and then you can try for your pregnancy, and you can wait for a period of 2 years. And once you conceive and you finish your breastfeeding, you can restart tamoxifen therapy. So what about triple negative? Because triple negative have a worse prognosis because they are more aggressive diseases and they tend to be high grade, and they're more common in young patients and who are BRCA positive, and they do not respond to hormonal therapy that target HER2 protein receptors. So it is this a group of patients where you require a neoadjuvant anthracillin-based chemotherapy. Basically, these subtypes also have a high pathological response to the therapy. So therefore, COS in triple negative patients, there's no increase in the risk of recurrence or a relapse. But as it is, the prognosis in triple negative patients is not as good as the ones who are not triple negative. They also have a low ovarian response to COS, and what they have advised is that it's better to go for fertility preservation before you initiate the neoadjuvant therapy in these patients. And any effect of COS and HR positive cancer. So the exact risk and benefit of COS in these patients is still being studied. And some studies suggest that COS could potentially increase the risk of cancer progression, especially in HR positive disease due to the hormonal changes associated with the stimulation. And in some cases, COS might delay the start of cancer treatment, which could potentially impact the outcome. So this is in ER positive and HER positive cases. So if you just have ER/PR positive, then there's not much effect on the survival rate. So I thank you all for such a good discussion. And I think we took more than
Thank you, ma'am. I
half
think we
hours.
had more take-home points to take
Half
and a
hours.
lot to learn from you.
Madam, it was a fantastic panel. And I think when Madam is a true, teacher.
Academician, yes.
She
And we
started.
actually we learned a lot from her
So
experiences. So it
that's
was
why,
like
I mean, I
it
didn't
was such
want to
such a good
disturb you all. I
opportunity.
wanted it to continue, and Dharam, Aditi, Divya, Ashwati, and even Tejas. Tejas was the rebel child. So, I mean, all of you were so involved that, I mean, it was a pleasure just watching you people. Madam,
Thank
thank
you
you
so
so
much,
It
much,
ma'am, for
Madhuri.
invitation, ma'am.
was good to discuss
It
with
was
the
Thank you,
younger
Monica, ma'am, for
generation.
such a beautiful,
Thank you,
such a
madam. Thank you.
fantastic
Thanks a
academic
lot.
So
program.
much, so
No, all
much
half
to
my
learn
age.
today
So
from you,
that
ma'am.
is
First
This is
to
all
form a
Sarin,
panel
ma'am.
like this, brainstorming.
This,
Thank,
this
thank
is
you,
all
I
Monica,
can
ma'am, for
I can
getting
see
Madhuri, ma'am.
I can see a sea of knowledge behind madam. So
yes.
her backdrop is also like that. And we could gather so much from that.
No,
You know,
travel is my passion.
the
So I
wealth of
go for
knowledge in
one
Madhuri ma'am is not only that practical knowledge, plus she reads such a lot. She teaches such a lot. I mean, I have seen it over the multiple webinars I've done with her that, I mean, you have to pursue, madam. I pursued her
See, it is
relentlessly.
like that. What my teachers taught me, and my teachers were so sincere. So I've got that is percolated into me that I also should teach my students.
Yes, ma'am. Yes, ma'am.
So
And now,
I think, and at no stage you should stop learning. I still learn. There are
yes.
several things what you don't know, but you can learn from others, even from the younger people, because they might be having a different experience. But I think learning should be a continuous process till you die. That's that.
So at the end of this webinar, I'm so very grateful to Dr. Madhuri Patil ma'am for the blockbuster panel which she has conducted so meticulously. And the panelists are sitting here till 8:35 p.m. It is testimony to the fact what a great teacher madam is. Madam, namaskar. आपको
Absolutely.
And I would also like to thank the immense amount, wealth of knowledge that Jatin sir and Sujata Kar, the amount of, depth to this webinar that both of them brought in. Dharam is sitting, Jatin sir, sir's son, and he's such a humble guy and, answering so sincerely. So, I mean, we are blessed. Thank you
Yeah,
so much on
that's
behalf
very
of
sweet. Thank you so much for
special.
having me here. Thank you, ma'am.
Thank you.
Thank you so much, Monica ma'am, for the invitation and for this superb academic session today.
The pleasure is all mine, Aditi. And I would like to thank my team of BSV, Priyanka Joshi, and the studio tech support, Nima, and my coordinators, Shweta and Purva. Of course, Garima is there. Garima was the one who, spearheaded the whole program of ovarian stimulation. So till we meet again, in July, we meet with yet another brainstorming session on a topic. You can always put in the group what topic you want next, so we can basically get an idea of what you're wanting to learn. Thank you so much and have a great weekend. Good night, everyone.
Thank you,
Thank
everyone.
you.
Thank
Thank
you.
you.
This session is there on YouTube